السلام عليكم.
عليكم السلام ورحمة الله وبركاته. دكتور أسامة، ازي حضرتك؟
أكرمك الله دكتور خالد، أسأل الله يومك إن شاء الله بإذن الله، وإن شاء الله بالتوفيق، وأشكرك على الدعوة الكريمة. أستاذ تامر.
نورتنا
اهلا
وشرفتنا.
وسهلا دكتور اسامه. ان شاء الله قدامنا 5 دقايق ونبدا الافتتاح على طول باذن الله.
إن شاء الله الرحمن بإذن الله. أنت في الدور الثالث ولا في المكتب بتاعك ولا فين؟ ألو؟ ألو، سامع الصوت؟ أستاذ تامر؟
سامعين حضرتك
تسمعني؟
دكتور اسامه؟ الصوت كده واضح
ماشي.
تمام.
الشمس ضاربة في عينك صح؟
مظبوط.
يس، أوكي ماشي يا باشا.
افتح الواتس.
أوكي غير. ماشي يا
يا
باشا،
ريت
خلاص إن
حضرتك
شاء الله
تفتح الواتس
بالتوفيق.
بتاعك.
أفتح الواتس بتاعي. أوكي ماشي يا باشا. أوكي جريت. شغال يا باشا. دكتور عادل شبك صح؟ دكتور عادل أول سبيكر شبك صح؟
مظبوط دكتور اسامه، موجود وجاهز معانا باذن الله.
إن شاء الله بإذن الله. أكرمك الله. ماشي يا فندم، بالتوفيق إن شاء الله. اتفضل يا أستاذ. كده.
وَلَقَدْ خَلَقْنَا الْإِنسَانَ مِن سُلَالَةٍ مِّن طِينٍ ثم خلقنا النطفة علقة فخلقنا العلقة مضغة فخلقنا المضغة عظاما فكسونا العظام لحما ثم أنشأناه خلقا آخر فتبارك الله أحسن الخالقين ثم إنكم بعد ذلك لميتون ثم إنكم يوم القيامة تبعثون
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين. الحمد لله إله الأولين والآخرين وقيوم السماوات والأراضين الذي لا فوز إلا في طاعته ولا عز إلا في التذلل لعظمته ولا غنى إلا في الافتقار لرحمته ولا هدى إلا في الاستهداء بنوره ولا حياة إلا في رضاه ولا نعيم إلا في قربه ولا صلاح ولا فلاح إلا في الإخلاص له وحبه الذي إذا أطيع شكر وإذا عصي تاب وغفر وإذا دعي أجاب وإذا عُمِل أثاب الذي لا تحلو الدنيا إلا بعافيته ولا تحلو الآخرة إلا بعفوه. فالحمد لله على ما أنعم به علينا من نعمه العظيمة حيث أنزل إلينا أحسن كتبه وأرسل لنا أفضل رسله وشرع لنا أكمل شرائع دينه وجعلنا من خير أمة أخرجت للناس. اللهم لك الحمد حمدا كثيرا طيبا مباركا فيه كما ينبغي لجلال وجهك وعظيم سلطانك عدد خلقك ورضا نفسك وزنة عرشك ومداد كلماتك. ثم الصلاة والسلام على سيد الأنبياء والمرسلين الصادق الأمين محمد بن عبد الله صلى الله عليه وآله وصحبه وسلم عبد الله ورسوله أرسله الله رحمة للعالمين وإماما للمتقين فشارح له صدره ورفع له ذكره ووضع عنه وزره وجعل الذلة والصغار على من خالف أمره. أشهد أنه قد بلغ الرسالة وأدى الأمانة وجاهد في الله حق جهاده حتى أتاه اليقين حتى أقام الله به الإسلام والملة إلى يوم الدين. أساتذتي وإخواني وأخواتي الأفاضل، أهلا بكم ومرحبا في مؤتمر المستشفى السعودي الألماني التاسع لطب الأمراض الروماتيزمية. In the name of Allah, the most gracious, the most merciful, the owner of the judgment day, peace be upon our beloved Prophet Muhammad, who presented to us the most beautiful, the most nice, and the most complete picture of the human being. No one can enter the eternal paradise except through his straight way, who are the believers, who were obedient slaves to their great only God Allah, who did the good deeds and avoided the bad ones. Ask Allah to guide us to be in His followers and gather us all in His eternal paradise, where will be no sadness forever, no troubles forever, and no death forever, but only happiness forever, wealth forever, and life forever. Welcome in Saudi German Hospitals Group. It's our pleasure and honor to have your kind acceptance to the invitation of our 9th Saudi German Hospital Rheumatology Symposium. And in a new world, our great only God Allah has permitted us to widen our knowledge, to deepen our realization in all sciences generally and the medicine especially. But still the field of rheumatic diseases is one of the most mysterious islands in the endless sea of science, as it is a very specialized branch of medical sciences. So deep, so complicated, no one can manage except its sole scientist, as it deals with almost all body organs, especially the highly powerful immune system that defends the human body in an environment full of enemies. Although our knowledge had improved much and still improving till the moment, but what is known is very, very little in comparison to what is already present. Same like an iceberg, where we can see clearly its small top, but know nothing about its major undersurface. Where we are still standing astonished, visualize the very nice creation, not only of the human body, but of the whole amazing universe that carries us the clue and key to know its only creator, the one and the only one great God Allah, the sufficient master, neither he begets nor was he begotten, and there is none co-equal or comparable to him. With his help and support, we will try in our symposium to dive in the rheumatology sea, to explore its mysteries and extract its nice pearls. And we hope to be useful one for both physicians and patients. At the end, I would like to welcome my great eminent professors who accepted our invitation to share with us their nice presentations and experiences. They are the leaders and pioneers of the rheumatology science. May Allah Almighty reward them generously. I'd like to thank also all who participated to evolve the Rheumatology Symposium dream to a successful reality in its 9th edition. The Saudi German Hospitals Management for their constant support and encouragement all over our work. My appreciation also extends to my brothers in the organizing committee, especially Mr. Tamer, my dear brother, the head of the academic affairs. Have a nice time and thank you so much. It's my pleasure and honor to start our symposium with my dear great professor, Professor Dr. Adil. He is one of the pioneers of rheumatology in Egypt, not in Egypt only, but in the Middle East. He is the professor of internal medicine and rheumatology, head of rheumatology department at Shams University Hospitals. Professor Dr. Adil Mahmoud is my dear professor. He was the supervisor for me for years. He taught me and tens of my colleagues morals before sciences. Please, Dr. Adil.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا أخي العزيز الدكتور خالد فتحي، وشكرا جزيلا على دعوتك الكريمة لي. وأنا دايما بأسعد بتواجدي معكم في مؤتمر السعودي الألماني في الرياض، ويعني بشكرك شكرا جزيلا. بشكر أخي العزيز الأستاذ تامر، بشكر كل القائمين على المؤتمر. بتمنى لكم كلكم التوفيق بإذن الله تعالى. كما أشكر إدارة مستشفى السعودي الألماني الحكيمة على موافقتهم على الدعوة الكريمة وأن أنا أكون مع حضراتكم. فإن شاء الله المرة الجاية نكون مع بعض بإذن الله فيس تو فيس بإذن الله تعالى. طبعا كمان سعيد جدا بوجودي مع الإخوة والزملاء من الأماكن المختلفة المشاركين في المؤتمر. ويمكن أنا شفت أخي العزيز الدكتور أسامة، فأنا برحب بيه جدا جدا جدا. وعشان ما نضيعش وقت حضراتكم خلينا نبدأ. أنا My presentation today is about psoriatic arthritis management updates. Actually, my agenda will include, after a short introduction, including the main features of psoriatic arthritis, I am going to highlight what is severe psoriatic arthritis and what are the associated comorbidities. Then I am going to go through the management of psoriatic arthritis, including the aim of treatment of psoriatic arthritis, as well as the key challenges in its management, predictors of achieving minimal disease activity. Also, what are the biologic and targeted synthetic DMARDs approved for treatment of psoriatic arthritis up till now? And before I conclude, I am going to highlight the draft of the new GRABA treatment recommendation for psoriatic arthritis. And let us start by heterogeneity. Heterogeneity is the hallmark of psoriatic arthritis. Why it is heterogeneous? Because inflammation will affect a lot of tissues, including the skin and nails, and definitely the joints. Also, the emphyses, I mean the site of ligaments or tendon attachment to bone, also is affected, as well as the tendons. The bone is markedly affected in psoriatic arthritis patients, and we have some patients with axial inflammation. We call them, they have axial psoriatic arthritis or axial PSA, not SPA, axial PSA. Actually, we have 6 domains for patients with psoriatic arthritis. The first one is definitely arthritis. It is nearly present in all patients with psoriatic arthritis. Skin psoriasis is prevalent in at least 80 to 80% of patients. Enthesitis, I mean inflammation of the tendon attachment, the most common is the Achilles enthesitis, occurs in up to 50%. Dactylitis, inflammation of the whole digit, whether in the hand or in the feet, and the inflammation will affect the soft tissues, the bone and the joints, as well as nail psoriasis and axial PSA or axial psoriatic arthritis, which may reach 60 or 70%, especially in the long-standing cases. Heterogeneity also is present as there is no solid biomarkers, no specific diagnostic test, as well as variable response to medications. As we all know, usually psoriasis starts first, then followed a few months or years by arthritis. This occurs in 75% of patients. The reverse may occur in 10 to 15% of patients, where arthritis starts first, followed by the appearance of psoriasis. And also in 10 to 15%, they may start coincidentally, I mean, the patient develop both psoriasis as well as arthritis at the same time. The main features of psoriatic arthritis include plus psoriasis of the skin, scalp, and nails. Nail psoriasis include pitting of the nails, splinter hemorrhage, leukonychia, oil spots, hyperkeratosis, onycholysis, a lot of manifestations in the nail. Dactylitis, which occur in up to 50% of patients. Clinical enthesitis. Clinical enthesitis occur in 50% of patients, but actually the main pathology could be considered enthesitis, and it is present in nearly all patients of psoriatic arthritis, but clinically prevalent, clinically evident in half of these patients. Arthritis, whether peripheral arthritis or affection of the DIBs, I mean distal interphalangeal joints, or axial involvement, also one of the important manifestations. And now we still use Moll and Wright classification of arthritis in patients with BSA. And as we know, around 50% of patients may have asymmetric oligoarthritis, especially in the lower limbs. Many patients may have rheumatoid-like arthritis, I mean symmetric polyarthritis. DIB affection occur in around 20% of patients, especially those having nail psoriasis. Arthritis mutilans, this is the end result of long-standing, untreated or neglected psoriatic arthritis, which may occur in up to 5% of patients, as well as axial PSA or axial psoriatic arthritis, where the patients may have asymmetric sacroiliitis, may have asymmetric syndesmophytes with a spine affection. Laboratory features may include plus absence of rheumatoid factor and ACPA. This is the usual, but we have some cases with rheumatoid factor positive. Also, they may have elevation of the acute phase reactants, including CRP and the ESR. Elevated serum uric acid is common in patients with psoriatic arthritis, and this is because the rapid turnover of cells and tissues affected by psoriasis. Radiographic features plus joint space narrowing, plus spurs which occur at the site of enthesitis, Asymmetric syndesmophytes and asymmetric sacroiliitis to differentiate from ankylosing spondylitis also may be evident, as well as erosions and bone resorption. Erosions and bone resorption may lead to the characteristic feature of psoriatic arthritis, characteristic radiographic feature, which is a pencil in cup appearance, and this is due to osteolysis, which may occur as you see here. The bone is resorbed, or there is an osteolysis which is progressive till we reach the characteristic appearance, which is the pencil in cup appearance. And it's important to be noted that pencil in cup appearance is not diagnostic for psoriatic arthritis. It is not specific for psoriatic arthritis, as it may be due to many other causes, but the most common cause is psoriatic arthritis, which lead to such radiographic feature. Now I will go to what is severe psoriatic arthritis. When we call severe psoriatic arthritis to be severe psoriatic arthritis is present if one or more of the following 7 features is present. So even one feature is sufficient to describe that psoriatic arthritis in this patient is severe. If there is erosions, if there is elevated markers of inflammation, including ESR and C-reactive protein, also if there is joint deformities, if psoriatic arthritis impairs the patient quality of life, also if there is musculoskeletal manifestations, including enthesitis and dactylitis, especially dactylitis. Dactylitis is one of the features of severe psoriatic arthritis. If it impairs the patient function or working ability, and also if it is a rapidly progressive disease. One or more of these features is sufficient to call psoriatic arthritis. So psoriatic arthritis commonly misdiagnosed, commonly underdiagnosed, and the consequences of failure to diagnose early and effectively treat early can be severe. So this diagram shows that this is the onset of psoriatic arthritis. After few months or years, up to 10 years, there is the onset of arthritis, and at that time, we call such patients not to have psoriasis, but have psoriatic arthritis. Within just 2 years, imagine with me, at least one erosion is present within just 2 years from diagnosis of psoriatic arthritis. After around 10 years, there are 5 or more deformed joints in more than half of patients with psoriatic arthritis. Severe disability may occur during the course of psoriatic arthritis. Also, psoriatic arthritis is not that simple disease. It is a disease with increased mortality due to cardiovascular complications. We have a lot of comorbidities associating psoriatic arthritis, plus osteoporosis, bone affection, plus cardiovascular disease and ischemic heart disease. There is the limitation of the basic daily life activity, limitation of the working ability, as well as the patients are more prone to infection, psychological aspect of the disease, including depression and anxiety, as well as pregnancy outcome. All these may lead to also increased morbidity and mortality. Imagine that every 10 patients with psoriatic arthritis, 4 of them have hypertension, 3 of them are obese, 2 of them have dyslipidemia, 2 of them have a psychiatric disease, including depression and anxiety. So we consider psoriatic arthritis is not that simple disease as many doctors and many people consider that it is a simple disease. Psoriatic arthritis is associated with impairment of the most basic daily life activity. The patient cannot lift a cup or glass to his mouth, cannot wash or dry his body, cannot dress himself, cannot pick up something fallen from him at the floor. So the most basic daily life activity are affected, and this leads to negative impact on the patient activities and ability to work. cardiovascular complication. And I remember that my dear friend, Dr. Khalid Fathi, thesis, I think during the MED or the master, I can't remember exactly, was about the presence of atherosclerosis in patients with rheumatic diseases, I think rheumatoid arthritis at that time. But both psoriasis and psoriatic arthritis, there is a systemic inflammation. There is a storm of inflammation. And this inflammation definitely will lead to a lot of metabolic complications, including insulin resistance, endothelial dysfunction. Hence, atherosclerosis will be prevalent and may lead to acute coronary syndrome or myocardial infarction. So, psoriatic arthritis is not simple disease. This is a research. This research was published in Annals of Rheumatic Diseases in 2016. Discussing the incidence and the predictors of the cardiovascular events in patients with psoriatic arthritis. And the conclusion of the authors included that a significant proportion of patients with psoriatic arthritis develop cardiovascular events during the course of their disease. Also, they stated that the increased cardiovascular risk is associated with both combination of the traditional cardiovascular risk factors as well as the psoriatic arthritis activity. And the predictors, independent predictors of the major cardiovascular events included the traditional risk factors as hypertension and diabetes, also included the number of dactylitic digits as well as the ESR in females. Also, the working ability. Imagine with me that patients with psoriatic arthritis have missed at least 20% of their working time. So, psoriatic arthritis is not that simple disease. This study comparing the comorbidities of psoriasis alone and psoriatic arthritis. And this column shows the comorbidities in patients with psoriatic arthritis. If compared to those comorbidities in patients with psoriasis, we will find that all the comorbidities in psoriatic arthritis are more prevalent than those with psoriasis without arthritis. And this study was published in 2011. Also, it was highly significant increased comorbidities in patients with psoriatic arthritis if compared to those with psoriasis regarding hypertension, respiratory disease, GIT diseases, neurologic disorders, as well as depression and anxiety. The comorbidities regarding these systems were highly significant in psoriatic arthritis if compared with those with psoriasis. And it is to be noted, and definitely patients with psoriatic arthritis have an increased 1.8-fold increased risk of death if compared to those general population without psoriasis or psoriatic arthritis. Actually, it is a disease, severe disease carrying a lot of comorbidities, a lot of morbidities and mortality. The condition starts early by inflammation. This inflammation definitely will lead to disability, but fortunately enough, this form of disability due to inflammation, due to pain, due to stiffness, due to swelling, and it's completely reversible if the patient receives the proper diagnosis at the proper time as well as the proper treatment. But definitely, if the patient didn't receive the proper diagnosis or the proper treatment, this inflammation will lead to destruction, will lead to damage, and this damage will lead to irreversible permanent disability. Hence, the early diagnosis and the early interference and management are important. Regarding the early diagnosis, this is the Casper criteria. Some of you now is saying this is a classification criteria. It is not a diagnostic criteria. How can I use it for diagnosis of psoriatic arthritis? I will answer you now. This the Casper criteria. The Casper criteria has a specificity of nearly 99%. 99%. exactly 98.7%, with a sensitivity more than 91%. So can be considered for a great extent as a diagnostic criteria. Casper criteria included the presence of psoriasis. Current psoriasis will be scored for 2, but past history or family history of psoriasis will take a score of 1. Nail psoriasis with a score of 1. Negative rheumatoid factor test also scoring 1. Current dactylitis or dactylitis diagnosed by rheumatologist before also have a score of 1. And lastly, radiographic evidence of juxta-articular new bone formation in the X-ray also has a score of 1. If the patient's score is 3 or more in the presence of active inflammation or inflammatory musculoskeletal disease, whether arthritis, enthesitis, dactylitis, this is sufficient to classify and properly to diagnose this patient as having psoriatic arthritis. And the early diagnosis is the job of both dermatologists and rheumatologists. Dermatologists are the first to see most of patients with psoriatic arthritis during the phase of psoriasis. And we have a lot of questionnaires. One of the famous questionnaires is the BEST questionnaire. Questionnaire is a screening tool, should be done by dermatologists for those patients having psoriasis in the dermatologist clinic. This is a screening tool to select those patients to be referred for a rheumatologist. And this questionnaire is constituted from 5 simple questions. Have you ever had a swollen joint? Has a doctor ever told you that you have arthritis? Do your finger nails or 2 nails have holes or bits? Have you had pain in your heel? Have you had a finger or 2 that was completely swollen and painful for no apparent reason? If the patient answered yes for 3 questions or more, this is sufficient to refer the patient with psoriasis for a rheumatology clinic to be screened for diagnosis of psoriatic arthritis and to start the treatment of psoriatic arthritis, not only treatment of psoriasis. And BEST questionnaire is validated screening tool. This is the BEST questionnaire in Arabic and also validated in the Arabic language. We can use it in the dermatology clinic and in the psoriasis clinics. Early management. Early management is crucial. Early management is very important because early management will allow you to stop and prevent complications and damage. What is the aim of management of patients with psoriatic arthritis? Not only prevention of organ damage, not only inhibition of structural damage, but also optimization of the functional capacity and the quality of life. So the selection of drug is very important because we have some drugs which prevent damage, prevent joint destruction, but lead to a lot of complications and side effects which will not allow us to optimize the functional capacity and the quality of life. Also improving working ability and relief of symptoms. And to sum up all these aims, we have to improve what we call health-related quality of life. This is the aim of management, but we have a lot of challenges in the management, especially in the manifestations, including severe psoriasis or extensive psoriasis, whether in the skin, nail, or scalp, peripheral arthritis, axial disease, enthesitis, dactylitis. Also, we have a poor prognostic factors. One of the following, when present, this patient have a poor prognostic factor. So when management patient with one or more of the following poor prognostic factors, you have to follow up the disease activity strictly and in a short intervals. The poor prognostic factors including the presence of 5 or more tender or swollen joints, the presence of extra-articular manifestations, especially dactylitis, the presence of radiographic damage with active inflammation, as well as elevation of acute phase reactants, including C-reactive protein. One of these 4 features is sufficient to classify your patient as having a poor prognostic psoriatic arthritis disease. What are the predictors, the reverse? What are the predictors of achieving minimal disease activity? But first of all, what is minimal disease activity? Minimal disease activity, including the tender joints are 1 or less, swollen joints are 1 or less, PASI score is 1 or less, or the body surface area is 3 or less. Patient pain by the visual analog score is 15 or less, as well as patient global activity by visual analog score is 20 or less. The presence of these 5 features means that your patients achieved minimal disease activity. If you added 2 other features, which is the health assessment questionnaire is half or less, as well as tender incisional point is 1 or less, this, if the patient achieved these 7 features, we call that the patient achieved very low disease activity score. What are the predictors of achieving minimal disease activity? If psoriatic arthritis started at young age, in males more is better than in females, low functional impaired, low C-reactive protein titer, lower enthesitis count, absence of dactylitis at the baseline, as well as short symptom duration. Now, what are the available biologic and targeted synthetic DMARDs and small molecules approved for treatment of psoriatic arthritis? First of all, anti-TNF. TNF inhibitors starting from 2002 by etanercept, 2 years later infliximab, 1 year later adalimumab was approved, 4 years later golimumab, and lastly certolizumab. These are the anti-TNF available and all approved for treatment of psoriatic arthritis. Also, we have a lot of biosimilars for anti-TNF and by extrapolation also approved for treatment and use in psoriatic arthritis. What about the non-TNF agents? Ustekinumab IL-12/23 inhibitor, phosphodiesterase 4 inhibitor apremilast, but it is not a biologic, it is oral small molecule. Secukinumab, ixekizumab, both are IL-17 inhibitor. Abatacept, T-cell co-stimulator inhibitor. Tofa, one of the JAK inhibitor, tofacitinib, as well as gozelkumab IL-23 inhibitors. All these are approved by FDA and EMA for management of patients with psoriatic arthritis. This is regarding the available medication. And before I conclude, I am going to highlight the new GRABA recommendation, which will be mostly published at the 2022. And the new GRABA recommendation, there is some modification from the previous one or previous version. Plus, considering which domain is involved, but also consider the patient preferences, the previous and concomitant therapies, the choice of therapy should address as many domains as possible. Also, you have to assess the disease activity, the impact and the prognostic factors present in your patients. There are 2 pathways, the standard therapeutic pathway, which will be shown as a straight line, and the dotted line is the rapid therapeutic route. Now, what are the domains? The peripheral arthritis. Peripheral arthritis, there is no marked change except the addition of some new agents, including IL-23 and JAK inhibitors, which are not included in the previous version of GRABA because they didn't, they were not approved at that time. But peripheral arthritis, we can use non-steroidal, conventional synthetic DMARDs, all the previous medications, including anti-TNF, IL-17, ustekinumab, 23, abatacept, JAK, abrimalast, all the agents can be used for peripheral arthritis. The second domain is the axial disease. As we all know that conventional synthetic DMARDs are not working in the axial disease, also ustekinumab and IL-23 are not approved for axial disease, so we can use non-steroidal, and if failed, we can go to biologic, including IL-17 inhibitor, anti-TNF, or JAK inhibitor. If the patient didn't respond, you switch your biologic. Regarding enthesitis and dactylitis, the treatment recommendations are the same, including non-steroidal, conventional synthetic DMARDs, including methotrexate, also all the biologics, and including also abrimalast or phosphodiesterase inhibitor. And if you fail to control enthesitis or dactylitis, you can switch between your drugs. Regarding the psoriasis, after failure of the topical treatment and phototherapy, you can go either to conventional synthetic DMARDs or the biologics, or the biologics could be used. And if there is no satisfactory response, you can switch between your agents. The same for nail psoriasis. After failure of topical therapy and conventional synthetic DMARDs, you can go to biologics. Also, the GRABA added 2 domains to the previous version. The first one is the presence of IBD. IBD associating psoriasis, or the patient have GIT complaints with elevation of the calprotectin, fecal calprotectin, you can go for anti-TNF excluding etanercept, go for IL-12, 23 or IL-23 inhibitor, JAK inhibitor, and methotrexate. And the last domain is uveitis. You can use either cyclosporins or anti-TNF excluding etanercept. This is the highlighting the GRABA recommendations, which will be available, I think, within 2022. Also, you have to consider the comorbidities and the associated diseases and the condition, because it may impact the choice of your therapy and impact also the periods of re-evaluation. You have to re-evaluation and follow up your patients, you have achieved your goal or not. Finally, if you give your right patient the right drug at the right dose at the right time, definitely you will have a better outcome. Dear colleagues and friends, now it is the time to conclude my presentation. Psoriatic arthritis is a heterogeneous disease and have a lot of domains. Previously were 6 domains, now 8 domains with the appearance of the new GRABA recommendations. Psoriatic arthritis is not that simple disease. It may lead to severe disability, as a lot of comorbidities and increased mortality. Early diagnosis and management are crucial for prevention of complications and the comorbidities. Nowadays, we are lucky because we have many conventional synthetic DMARDs, biologic DMARDs, targeted synthetic DMARDs, approved and proved effective for controlling psoriatic arthritis domains and activity, hence preventing damage and disability. Finally, I'd like to thank you all very much for your kind attention. شكرا جزيلا. Thank you, dear friend, Dr. Khalid. أتمنى لكم كل التوفيق والنجاح بإذن الله. شكرا جزيلا.
Thank you, Professor Adel, for your nice usual presentations. ما شاء الله لا قوة إلا بالله. We have a few queries. Regarding comorbidities, is controlling disease activity enough alone to manage, or must be managed separately?
Actually, we have to manage the disease activity and the comorbidities. I mean, if you have patients with psoriatic arthritis and have dyslipidemia or obesity or hypertension, it's not enough to control psoriatic arthritis. You have to add medications to control the patient lipid profile, to control the patient blood pressure, and to advise the patient to decrease weight. So, plus controlling psoriatic arthritis, you have to control the comorbidity.
Thank you so much. Another question about what is the difference between classification criteria and diagnostic ones?
Diagnostic criteria should carry specificity 100%, sensitivity 100%. This is the diagnostic criteria. 100% specificity, 100% sensitivity. I mean, 100% specificity, it means there is no patients with psoriatic arthritis will not be included in this criteria. 100% sensitivity means that there is no patient with other disease will be included as having psoriatic arthritis by this criteria. This is what we call classification criteria. But as Casper criteria, having a specificity nearly 99%, sensitivity nearly 92%, so we can use it for a great extent as a diagnostic rather than classification.
Excellent. The last question, what score of measuring disease activity you recommend in daily clinical practice?
We have a lot of score. As I usually say, measure but what you want, but it is to measure, but whatever the measure is more better and degrade than not to measure at all. You can use the DAPSA score. DAPSA is simple. You can count the tender and swollen joint, including the C-reactive protein, and assess the level of pain. So whatever the score you need, but I recommend the DAPSA in the National Institute of Health guidelines and protocol for use of biologic therapy in Egypt. I recommended for the rheumatologist to use the DAPSA score. DAPSA is simple, but it is not the only score we can use. We can use minimal disease activity, a very low disease activity score. But my advice is to score your patient better than not to score at all.
Thank you so much, my dear professor. It's nice presentation as usual. Thank you so
شكرا
much.
جزيلا أخي العزيز دكتور خالد. شكرا لكل الزملاء. أتمنى لكم كل التوفيق من خالص قلبي، وإن شاء الله المرة الجاية نكون مع بعض فيس تو فيس بإذن الله. شكرا جزيلا.
جزاك الله خير. جزاكم الله خير. We shift to the second presentation. It's my pleasure and honor to present my dear Professor Dr. Osama Haji Ahmed, the Senior Consultant Rheumatologist Muasat Hospital in Dammam. He's Associate Professor in Ain Shams University. He will present a nice topic, nice hot topic, COVID-19 and rheumatic diseases mapping the future. Professor Osama.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It's a great pleasure for me to be with you today. It's a happy day for me, happy evening to be with Dr. Adil, Dr. Ahmed, Dr. Sulaiman, Dr. Khalid in my old home, South German, and forever it is my home. I chose this topic because it touches us in daily clinical practice, and still the future is not clear. The point here that we have to remember our colleagues on the health team all over the globe that passed away because of this COVID-19. And we have to remember every one of them, either as a patient, either as a colleagues. Rahmatullah alayhim ajma'in wa afa bani adama kullum ajma'in. Still, we have a big problem in COVID-19. This is the latest update up to the left. This is the 4th October, 9 p.m. Still, we have a major problem still in COVID-19. The total number of the cases is 235 million cases, and this we are approaching 5 million. This is a huge number, so we have to take it serious as it is serious. And I think even if WHO declared that the pandemic is off or turning everything going back to normal, still we have to remember that we have 3 waves of cases and still the number of deaths did not go to 0. So we have to take care about this. Why we have to take care? Because in this match of knowledge and awareness, still we don't know what is unknown. Yes, we may know something about COVID-19, but still the unknown which need exploration, it's more than unusual. This is the SARS-CoV-2, but you have to take care that most of the vaccine is related to S protein or nucleic acid, but it states this is applied to, or my presentation is applied to the vaccination, which is approved by FDA or EMA, and not by, in Egypt, the China vaccination. So we have to take care if you are dealing with life attenuated. All vaccination is approved by FDA is not life attenuated, so we have to take care when we manage this patient. This is the SARS-CoV attached to ACE2 receptor, and we have to be familiar that it is a dangerous disease, and although it affects the airway primarily, how it is affected, it is in a very simple way due to, number one, direct cytotoxic effect, number two, dysregulation of the SARS of RAS system, endothelial cell damage and thromboinflammation, dysregulation of immune response that may end in cytokine release syndrome. What does it mean? In a simple way, either a direct cytotoxic effect, epitheliitis, endotheliitis. Remember, this the same mechanism of action of SLE or vasculitis or antiphospholipid syndrome. It may share the same mechanism, but it is not only the lung. The brain, the eye, the nose, the liver, the kidney, the intestine can be affected. So we have to take care in at least in next 5 to 10 years of atypical manifestation, especially if we are looking for diagnosis of systemic connective tissue disease or systemic lupus erythematosus. Yes, we have to differentiate to 3 stages. The stage 1, which is an early infection, the stage 2, which is pulmonary phase, the stage 3, which is the most dangerous one, hyperinflammation phase. The viral response phase, it should be subside with time, but the host inflammatory response is increasing by time. This is not too contradictory. The dangerous is the host inflammatory response. And the symptom may be mild, may be severe enough, and the clinical symptom, we have to take care, especially we are dealing with a patient with a chronic disease receiving immunomodulatory or immunosuppressive medication. So the patient may present with atypical manifestation. So we have a potential therapist. This is an old in 2020. We have a more updated about this, but at least we have to take care what is the proper time to use immunomodulatory agent early. Yes, sir.
Excuse me, but can you share the presentation? It's not clear.
It's not clear.
You cannot share, can you share it from your side?
دكتور أسامة البرزنتيشن مش موجودة خالص. أعملها شير بس. سامعني؟
يس سامعك يا
ماشي.
حاضر.
على مالك على مالك. في حاجة.
أنا عندي مشكلة في السيستم. أنا آسف for this.
يا ريت حضرتك بس تفتحها الأول على الجهاز وبعد كده تعمل لها شير سكرين. اوكي.
أسامة أنت خبرة، احنا بنتعلم منك.
جهاز اوكي.
حسدت بس.
اوكي. I cannot share. I don't know why, but I cannot share now. I cannot share, Dr. Khalid. Sorry for this. I will continue. You hear me? Dr. Khalid? You hear me?
Yes, I can hear you, Dr. Osama. I can hear you.
Sorry for this. There's something wrong in the system, right? It's okay. I will fix it.
So can we?
Yes, تفضل. I will manage with the clear.
لا no problem. يعني you need to take the other lecture till you fix.
Yes, it will. The problem in the system. I will fix it and I will make it tomorrow, inshallah. Sorry for this, my own colleagues, my dear and organizer. Going back for the common symptom, it can be fever, it can be dry cough, it can be fatigue, or we have to take care that the patient may present with any symptom, either an uncommon symptom or severe disease. Not all the patient would go to ICU, not all the patient would end by death. The problem is we have to take care what is the clinical window of opportunity. If you will not catch the patient in this short time, most probably you will miss control for this patient. The patient may end in cytokine storms that it's coming by clotting, shock, lung injury, cell death, immune paralysis, renal failure. It is due to inflammation and organ failure, the infection, it can end in death of the patient. There's a lot of controversy for this. Cytokine release syndrome, it is the same like the end stage of COVID-19, still it is a great debate. Acute respiratory stress syndrome may be overlapped with the COVID-19, may be overlapped by MAST or familial HLH. Still, the future will tell us what is common and not common. It is not each medication used to treat COVID-19 will be directed to the immune suppressive effect or immunomodulatory effects. It is related, may be related to viral load. What does it mean? Chloroquine, that before there's a great debate about this, it decreases the viral load. Baricitinib can decrease the viral load. Leflunomide can decrease the viral load, but it is not a treatment for COVID-19. So the point is that our patient is liable to have a severe disease for COVID-19 or not. The answer is yes. Patient with RA, patient with immune-mediated joint disease, they are in comparison to the general population, they are increased. This is published in August, Annals of Rheumatic Disease by Time. And what about the comorbidity, which is more common for this patient? That it is published in Annals of Rheumatic Disease, July 2020, that the patient with hypertension or cardiovascular disease or lung disease or diabetes or chronic renal failure is more common to have a severe form of COVID-19. Remember that most of our patients, either SLE vasculitis, they have a lot of comorbidity. Hospitalization, it's common in all, but lupus and vasculitis, as expected, it's more common to be in COVID-19 patient. All these data is related to the Global Rheumatology Alliance. And the most important, what about the medication? Lucky enough that not all medication affects the disease except one which is steroid. Fair enough, steroid not the problem. Why? Because if you are giving steroid as a patient, it means that this patient has a severe or active disease. So if this is related to the immunosuppressive immunomodulatory effect of steroid or related to this disease, it is not common or no clear answer for this, but at least our patient is a critical situation if the patient received prednisolone 20 milligram or more. But for conventional synthetic, biological synthetic, it's not enough. What is the safest portion for this? It is TNF. Prednisolone dose, it is the most important that if the patient is receiving more than 10 milligram, the patient is a critical situation. How COVID-19 or SARS-CoV can affect our future? I remember when I was in master thesis, my title was the effect of Epstein-Barr virus on rheumatoid arthritis. With this very common, widespread SARS-CoV can affect our immune system, can affect our diagnosis and treatment. The answer is yes. Through what? So immune senescence, the same like rheumatoid arthritis, molecular mimicry, the same like rheumatic fever, autoimmunity and autoimmune response like SLE. So in the future may tell us what's happening. If there's any correlation between COVID-19 and the rheumatoid arthritis, the answer is yes. This is from Shedet. It is Nature Review of Rheumatology 2020 in August, that the same either IL-6, TNF, GM-CSF induction, IL-1, IL-17, it is affected by both of the same mechanism or likely to be like COVID-19. The same cellular process, it is by resident macrophage and BMN, a macrophage infiltration, T-cell infiltration, and fibrotic response. So we may see that we are misdiagnosis. The most interesting point for me is about lupus anticoagulant beta-2 microglobulin anticoagulants. Why? Because up to 50% of the patients with COVID-19, they have a positive antiphospholipid antibody. So we have not to misdiagnose the patient with antiphospholipid syndrome or SLE based on autoantibodies, and we have to take care that at least we have to put COVID-19 in the differential diagnosis as a typical or typical manifestation in the differential diagnosis in the next 5 to 10 years. So what about the long COVID? We have a serious problem with long-term COVID-19. Why? Because we may have a permanent organ damage, classic post-critical illness symptom. The patient may have on and off, or the patient may have long-standing fatigue and brain fog syndrome. And the interesting point is fibromyalgia. Why? Because this is in August 2021 in Open R&D. They are very interesting that the male patient and the obese patient, the incidence for hospital admission and treated with supplemented oxygen and ICU admission, this is increased if the patient is male or if the patient is obese. So we have the term the fibro-COVID related to fibromyalgia. So we have to put this in our mind. And the second most important, what about vaccination? If the response or immunization by SARS-CoV vaccination, it will be the same for our patient like general population, the answer is no. The answer will be delayed or blunted response or extended response. It is not like the general population. And the point here that if your patient is immune-mediated inflammatory disease, the response for SARS-CoV vaccination, it is not like the general population. And by the way, vaccination does not mean immunization. Vaccination that you are taking the precaution. If your patient has already neutralizing antibody, if your patient has IgG against SARS-CoV, this is a story, is totally too different. And the point, this is an interesting case, and again, sorry for this, because I am away from my home. This is the problem. And if your patient not responding to the first or second dose, the patient may respond to booster dose, a third dose or the fourth dose. We have to take care about this, especially that we have no diagnostic tool or lab to say this patient is already immune against SARS-CoV. Methotrexate can affect the immunogenicity of BioNTech Pfizer messenger RNA. If you are comparing methotrexate with no methotrexate, methotrexate can affect the immune response against the vaccination. So either your patient is more than 55 or less than 55, it will be affected. The most dangerous point for me is rituximab obesity depression therapy. So if you are starting rituximab from beginning, you have to be fully vaccinate your patient. If your patient taking rituximab, you have to withhold the vaccination just before the second or the next dose of rituximab. The second does not mean after 2 weeks. The second will be after 5 to 6 months. Again, MMF or mycophenolate can affect the immune response. This is again from Australia, the previous one from Maryland. And we have to take care that if your patient is vaccinated, it may affect disease activity, either RA, psoriasis, or ankylosing spondylitis, SLE. But lucky enough, it is not a major exacerbation or increased disease activity. It's just a minor one. So we are lucky enough. what we can use, we have to vaccinate our patient by all means. We have to follow the CDC, MOH, and American College of Rheumatology guidance. And we have now in October 2021, the guidance for vaccination. And the most important for me that we have to differentiate between two different items. The first one, which is an autoimmune inflammatory rheumatic disease, immune-mediated rheumatic disease, and other RMD. So if your patient like osteoarthritis, osteoporosis, fibromyalgia, we are not serious enough in taking this. But if your patient is osteoarthritis and receiving methotrexate for minor part of osteoarthritis or reason of osteoarthritis, this patient we have to take care about this point. But the most important is an autoimmune, immune-mediated rheumatic disease. Age is a very, very important risk factor, especially older population, 60 and more. The sex, male patient, diagnosis is very important. If your patient is SLE or vasculitis, totally different from RA, and they are more liable to be reactive for the vaccination. The patient must have a stable disease activity, but it is not a barrier to vaccinate your patient. What about the medication? What about the comorbidity? We have to take care that the vaccination for this patient priority. If your patient is receiving hydroxychloroquine, sulfasalazine, leflunomide, it is very important that there is no barrier to make any adjustment. But if your patient is receiving rituximab, you have to postpone the vaccination just before the next rituximab B-cell depletion therapy. What about other medication? The other medication is very important that MMF, you have to stop 1 week before each vaccination dose. Methotrexate, you have to withhold. What does it mean? If your patient taking methotrexate on like Friday, the second of the dose for vaccination, I prefer to be in the same day, and we have to withhold methotrexate for 1 week after vaccination. The same for JAK inhibitor. The beauty for JAK inhibitor that it is short-lived medication. So if your patient receiving each dose of vaccination, you have to stop it for 1 week at least. Abatacept is a subcutaneous or IV. It is very important. You have to stop 1 week before the first dose. 1 week before the first dose. Why this? Because you are in need of naive or T cell to make an immune response against SARS-CoV. Cyclophosphamide, you have to give it away from cyclophosphamide. We have to give it away from rituximab because it affects the efficacy of the vaccination. Non-steroidal, you have to stop non-steroidal 24 hours before vaccination. You can use it after vaccination. Remember that it is 76 recommendation, but 16 only is a strong recommendation. Most of it is moderate and it's not following. By this, and again, sorry for this miscommunication, and waiting for any comment for your side. Dr. Khalid.
Thank you, Dr. Osama, for your nice presentations as usual. It's concise, mashallah, and a very hot topic.
I will fix the problem. Yes, tomorrow lecture it will be solved.
Yes. Do you hear me? What is your recommendation for cutaneous vasculitis post first dose of AstraZeneca vaccines? Subside within 2 weeks with steroids regarding next dose of vaccine, which type and risk of vasculitis with other types of vaccines?
I have a very interesting case, more difficult than this. She was a 62. She's afraid from vaccination. She don't like to take vaccination. I'm trying to assure her it is not recommended to make any screening by lab investigation, but I did for her CBC, ESR, serum ferritin, CBK, lupus anticoagulant. I found lupus anticoagulant is positive. I make for her beta-2 microglobulin, it was positive. So my trend for this patient, for me, it is the most difficult patient that I ever met in COVID-19. I consult pulmonology and cardiology. We decide that the patient must be vaccinated. We give her 1 month for anticoagulant. It's okay. and the patient is vaccinated. So the guidance say if the patient received the first dose of Astra, the patient must have the second dose of the same company, except if the patient has severe allergic reaction from this vaccination or the severe manifestation of the allergic reaction or whatever side effect, then you can shift to another. But for Astra, there is a report about the clots. So if you are giving the patient antibiotic for short course, it can be safe. But for vasculitis, we have to take care about vasculitis. We have to take care about SLE, especially if the patient has an active disease. But in general, the patient must be vaccinated. This is the general rules. I prefer to tell my patient like this in Arabic. If they are afraid from COVID, right? I say, which one is better for you, to be blind or to be single eye? It's okay. الأعور ولا الأعمى؟ وبالتالي الأعور أفضل من الأعمى. وبالتالي we have to vaccinate your patient, whatever the side effect it would be. The side effect of vaccination is manageable, but COVID-19 can be ended by lab death. Khalid?
100 times or 1,000 times the complications of the vaccine. Thank you. In infected patients on biologics, if a patient on biologics had been infected, how long to stop post-recovery?
Yes.
Dr. Osama, do you hear me?
Yes, I hear you. The American College of Rheumatology say that it is a guidance. It is not like guidelines like ACR or BSA. It is just guidance. Even if the patient is admitted to ICU, it's okay, and the patient is stable, it's okay. You have to vaccinate the patient after discharge from ICU. So if your patient has a COVID infection, right? For how long are you giving biological therapy against the virus itself? 3 months after, you can vaccinate your patient. But if this is not related to the biological therapy, just related to infection, there are controversy between 3 to 6 months. But if it is not COVID, just a chest infection or upper respiratory or urinary tract infection must be subside and controlled. Then you can completely subside of infection, and then you can vaccinate your patient as early as you can. During this period, you have to give an instruction to the patient to be isolated, not to be socially exposed as much as he or she can.
When we restart biologics, these medications after recovery?
Yeah, I will, if the patient receiving TNF inhibitor, most probably it will not affect the course. But if the patient taking JAK, you remember JAK is inhibit the gamma interferon. So we have to take care of this. Why? Because if you are giving JAK and at the same time you are vaccinating your patient, it will affect the immunogenicity. So you are planting the immune response. So you have to withhold the JAK for 1 week. 1 week, and again, you can restart again. Methotrexate, you have to stop it for 1 week. Abatacept, you have to stop 1 week before and 1 week after the first dose. But the second dose, no need to stop. Biological therapy, you can resume again after 1 week or 2 weeks if the patient has a mild manifestation. But disease activity must be controlled. And we have not to depend on a steroid to cover this disease activity, exacerbation of disease activity by steroid.
Thank you so much, Dr. Osama. I enjoyed this very interesting lecture. Yeah, thank you so much.
Sorry for this, and tomorrow I will fix the problem, inshallah.
It's our pleasure. Thank you. Thank you so much, Dr. Osama.
It's great to see Dr. Omar. منور كالعادة.
We'll shift to the last lecture in our session with my dear Professor Dr. Gamal Atiyah. He's a consultant of the Rheumatology Department, Saudi German Hospital Al Asir. He is the Professor of Rheumatology in Faculty of Medicine at Al-Azhar University in Cairo, Egypt. Dr. Gamal will present a nice, interesting lecture. Why is vitamin D important? Please, Dr. Gamal.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank my colleague, Dr. Khalid and Mr. Kamil for this invitation as usual every year. I hope, as Dr. Adil said, next year, inshallah, face-to-face, bismillah. Actually, why I said vitamin D is important, last 5 years or last 10 years, a lot of patients came in clinic and asked me, do vitamin D, we have a problem, vitamin D, have a deficiency. From collection of lot of patients about vitamin D, I very interesting by this topic and go deep to search about vitamin D and how this one is very important and how is linked to some disease. Actually, vitamin D is one of soluble of vitamin. Our immune system need a vitamin D level at normal level to do their job is very well. Vitamin D plus calcium and phosphorus is very important for bone growth and bone healing. Our objective, I will remember with all of us, physiological function of the vitamin D, effect of vitamin D deficiency in disease state as well as in healing, determine who at the risk of deficiency of vitamin D. Vitamin D has important role together with calcium for metabolism of the bone growth, important nutrient in preventing many chronic disease, a major biological function to maintain normal level of serum calcium and phosphorus. As we know, the calcium is very important minerals for action of muscle, especially cardiac muscles. The most cell of our body have a receptor of this vitamin D. By these receptors, the vitamin D has a wide range of biological action, especially inhibiting cellular proliferation, inhibiting angiogenesis, stimulating insulin production, inhibiting renin production, stimulate production of kill bacteria, as well as its own destruction. It is not just vitamin, it is pro-hormones existing over 500 million years. Cod liver oil is a common medicine, discovered antiretic factor in 1920 and discover conversion 7-DHC dihydroxycholecalciferol in skin in 1937. Food in some found in some food and made as a biological factor after exposure to ultraviolet. We have two groups of sterol for vitamin D. Vitamin D2 orgocalciferol, this is a plant origin. And vitamin D3 cholecalciferol, this is the animal origin and produced by action of ultraviolet in 7-dihydroxycholecalciferol in skin. The human and the animal used only vitamin D3 and they can produce it inside their body. Cholesterol is converted to 7-DC, which is the precursor of vitamin D3. Sunlight converted 7-D3 to cholecalciferol. Vitamin D3 is metabolically inactive until hydroxylated in kidney and liver to active form 1,25-dihydroxycholecalciferol. This is the active form of vitamin D. 125 or active form of vitamin D, this is the physiological active form with half-life up to 6 hours. On other side, 25-hydroxyvitamin D3 is inactive form and measured clinically in serum and the indicator of vitamin D stored in the body and the reflect amount taken from the food under the sun with half-life up to 3 weeks. In lab issue, the vitamin D may be sufficient if the level up to 30 nanogram per milliliters. Insufficiency of the level of vitamin D below 30 nanogram per milliliter but deficiency can be classified into 3 groups. Mild, between 20 to 30, moderate, 5 to 10, and the severe deficiency of the patient to have the level below is 5 nanogram per milliliters. We have a link, or good link, between high latitude and deficiency or chronic disease due to minimized sun exposure. The high altitude increases the risk for many chronic disease. Vitamin D synthesis and level is negatively correlated with latitude and positively correlated with sunlight. Any people living at this level actually more or less have a normal range of vitamin D, but anybody, anybody living above or in high latitude, actually he is not exposed to the sun by enough times, maybe have, or we suspect to this one, have a problem in deficiency of vitamin D. Deficiency of vitamin D leading to chronic disease like diabetes, kidney, osteoarthritis, rheumatoid, schizophrenia, autoimmune. Here, just to remember you, the vitamin D deficiency not lead to this disease, but if we can correct the vitamin D with this disease, can be improve the management of the problem or the management of chronic disease. Vitamin D antimicrobial. Vitamin D produce antibiotic peptide that attacks the germ, especially virus and bacteria, produce many enzyme, protein, and the regular factor and the regulator factor, especially interleukin-1. Recent published report show 2,000 international unit of vitamin D is complete abolishes the occurrence of upper respiratory infection in adult during winter months. Antimicrobial of vitamin D involved in erythrogenesis and immune response. Adequate vitamin D in macrophage decrease uptake of oxidized particles, decrease foam cell formation, decrease cholesterol ester formation, permit cholesterol to move out of macrophage and suppress macrophage migration to other site. Anti-inflammatory of vitamin D, a daily dose of vitamin D in the dose of 2,000 international units of vitamin D increase the anti-inflammatory of cytokine 10 and decrease its pro-inflammatory tumor necrosis factor in congestive heart failure patients. Autism and the vitamin D animal data, vitamin D deficiency during gestation affect the dosing of protein involving in brain development. Vitamin D deficient in rat are born with increased brain size and enlarged verticals. Children with vitamin D deficiency, rickets has severe autistic marker that disappear with high dose of vitamin D. Autism is more common at higher altitude due to minimize or low dose of sun exposure. Vitamin D anti-cancer may be influence both incidence and mortality, linked with GIT cancer, prostate and brain cancer, lymphoma, and endometrial carcinoma. Vitamin D prevent tumor angiogenesis and maintain healthy calcium and concentration inside the cell. Vitamin D also enhances cell death with appropriate. Vitamin D anti-cancer receptor found in malignant melanoma cell and myeloid leukemic cells. The active form of vitamin D inhibit melanoma cell proliferate and induce myeloid cell differentiation. Female who regularly take vitamin D3 and the calcium had a 60% reduction in all cancer incidence compared with the placebo, and this study is published in American Journal of Clinical Nutrition. Hypertension, as we know, is the peak of this hypertension in winter. Vitamin D is potent endocrine suppressor of renin biosynthesis. Increased renin led to hypertension. Supplementation with vitamin D3 and the calcium reduce the blood pressure in elderly. Low level of vitamin D double risk for cardiovascular disease. Supplementation by vitamin D reduce the risk of diabetes by about 80% in children. Vitamin D might protect pancreas. Supplementation of mother diet reduce the incidence of type 1 diabetes in children. Children who are deficient in vitamin D, 200% increase the risk of development type 1 diabetes. The main source of vitamin D, as we know, is sunlight or exposure to sunlight. We have some kind of food like fish, liver oil, fish and seafood, egg, and as we know, the plant is not contained as vitamin D3. Sun exposure have a benefit as well as have a harmful for the skin, especially skin cancer. Vitamin D can be getted from ultraviolet induced by photosynthesis in skin. Sunscreen or sunblock can block the biosynthesis of vitamin D by ultraviolet. So the ultraviolet light from the sun can be divided into 3 bands: ultraviolet A, B, and C. B is the primary causes of sunburn as well as produce the vitamin D in our skin. The amount produced, the amount we get it from the sun exposure is dependent on exposure time, geographic location, pollution, and the amount of skin exposed, as well as a skin color. All this can be affect the percentage of vitamin D we can get it from sun exposure. How much is the time we need to get the enough vitamin D to our body? For the most people, 2 to 3 hours per week in summer monthly, with half of our skin is exposed, can be enough to give us the dose of vitamin D. The best time is middle of the day that have been warned to avoid it. 30 minutes of sunlight between 10 a.m. to 3 p.m. Actually, if we can expose to the sun from 30 minutes to 45 minutes per week, we can give us 13,000 of international unit of vitamin D, as well as the dose of vitamin D kept under the skin for 3 days. How much is the sun we can get it? This depends on the age. As we know, old age or aging, the skin thickness become very thin, and we need more sun to compensate the thickening skin. Amount of vitamin D can be taken from the food, skin darkens, and sunshine intensity. Significant skin exposure should be expose the face, neck, arm, hand, and the leg. Adequate sun strength, the time, 25 of the time, it causes thickness of the skin, especially in Caucasian. People with dark skin require significant more sun exposure. Regarding assessment of vitamin D, lab measure, we measure 25 hydroxy vitamin D as well as 125 dihydroxy vitamin D. 25 is the reflected total amount of vitamin D. D2, D3 have a similar biological action. Do not use الactive form اللي هو 125 dihydroxy vitamin D. This can be even normal with vitamin D deficiency. 25 dihydroxy concentration to prevent the deficiency should be kept above 25 nanomole. To prevent insufficiency should be above 50. For maximum bone health should be kept between 75 and 100 nanomole. We have a lot of food have vitamin D, but all cannot replace the sun exposure. The sun, after exposed to the skin gives us the active form of vitamin D. This process not easy like this one. We have a lot of process inside our body to get the active form of vitamin D. How can do this? We get the vitamin D in 2 forms, D2 and D3. After getting this one stored in skin, ultraviolet of the sun activated this one, it D2 to cholecalciferol, it D3 to cholecalciferol. Both in the liver, in the presence of 25 hydroxylase enzyme, we get the inactive form of vitamin D, 25 hydroxy vitamin D. So if we have a patient have a problem in liver, we suspect this enzyme is not working as well, so we can suspect 25 or inactive form of vitamin D is a deficiency in this patient. After formation or after release of 25 hydroxy vitamin D from the liver, go to the kidney. In the kidney, by 1-alpha-25 hydroxylase enzyme in kidney, push the kidney to secrete the active form of vitamin D, 1,25 dihydroxy vitamin D. Also here, if the patient have a problem in kidney, especially renal dialysis, the active form or this enzyme cannot working well, so this patient we suspect to have severe deficiency of active form of vitamin D. The active form of vitamin D plus BTH act in renal, proximal renal tubules to producing the active form of vitamin D, 1,25 dihydroxy vitamin D. After release of active form of vitamin D, the main target of action of this active form of vitamin D to maintain, to act in major organ, to act in the bone, to activate the osteoclast, and act on GIT to do or enhancing formation calcium binding protein. So the target of active form of vitamin D to maintain serum calcium inside the body by act on osteoclast to do bone destruction to increase the calcium serum level, as well as act on GIT to enhancing endothelial cell to do calcium binding protein. If we have a patient and take lot of calcium, even 2 to 3 grams per day, without calcium binding protein is not benefit or no benefit from this one, because the calcium in GIT, if not found, calcium binding protein can be lost in stool. In active form, we have another alternative pathway in kidney, in normal serum calcium and phosphorus and low BTH. Another enzyme, 25-24 hydroxylase enzyme, act on the kidney to convert it 25 hydroxylase enzyme to 25-24 dihydroxylase enzyme, and this one in active form. Serum calcium in our body is depend on the absorption of calcium across GIT cell wall, reabsorption of filtrated calcium by renal tubules, resorption of calcium from the bone. To get this, should be have a calcium binding protein. This is very important to protein to maintain serum calcium level in normal level. So the synthesis of calcium binding protein depend on active form, not depend on inactive form, to enhance the messenger RNA in endoplasmic reticulum to synthesize this polypeptide. The main function in bone development of vitamin D, cell differentiation, immunity, important for cell-mediated immunity, coordination of immune response, as well as it act as a hormone to regulate gene expression and cell growth. Therapeutic use of vitamin D for rickets, stomalacia, osteoporosis, psoriasis, cancer, and autoimmune disease. Toxicity of vitamin D, not from vitamin D itself, but the toxicity came from hypercalcemia. If the patient have high dose or serum level above 100, the toxicity came from hypercalcemia, and this one is manifested by nausea, vomiting, excessive threat, severe itching, joint and muscle pain, and disorientation and coma. And this is the recommended dose by FDA for the dose of calcium, vitamin D. So the where to go from here? We do screening or routine screening of our patient, rectify deficiency and insufficiency, maintain the level through the combination diet and sun exposure, increase the consumption of food that have the vitamin D supplementation during the winter, annual testing in active form 25 dihydroxy vitamin D, consider time of year in testing, lowest level generally toward the end of the winter and early spring. Thanks. Thank you, Dr. Health.
Thank you so much, Professor Gamal, for this nice presentation. We all need vitamin D. What is your recommendation for vitamin D dosing regarding loading and maintenance?
Maintenance dose 1,000 per day. The maintenance dose for vitamin D 1,000 per day. But if the patient have a deficiency, we can give at least 2,000 to 3,000, or we can give 50,000. This is available in marketing. 50,000 per week. This is the best dose.
For how long?
At least 3 months to be checked again by the blood test.
Do you recommend checking vitamin D? Frequent checking?
In the past, we cannot check this one, but now after the dilemma of the vitamin D, I think every patient came now and asked me to check the vitamin D. No problem to check now.
Do you recommend plain or active form of vitamin D?
Inactive form, this reflects the percentage of vitamin D inside our body. But when we recommended to do the active form, اللي هو 125 dihydroxy vitamin D, if the patient have a normal level of vitamin D and he still have a problem, should be do active form, اللي هو 125.
In renal impairment يعني ولا?
Yes, in renal impairment. Also, if the patient already have a problem from deficiency of vitamin D and you give him the medication and he not correct the problem, should be do the active form.
Thank you so much, Dr. Gamal. Excellent presentation for a nice topic.
شكرا.
We came to an end for our first session.
دكتور خالد
اتفضل دكتور اسامه. ظهرت البرزنتيشن.
يا اتس اوكي. الاوليه كانت النشره، دلوقتي موجز الانباء 3 دقائق.
لا اتفضل.
Yeah, sorry for this. It's okay. This is a globe. It's okay. It is updated in 4th of October, 9 p.m. We have a major problem that the number of the cases is still too much high, and we have to
Dr. Osama, the voice is not clear.
Yes, clear now? Yes. We have a major problem for COVID-19. The number of the cases is 235. Number of deaths approaching huge number, unprecedented even by Spanish flu. The pathophysiology of COVID-19 is due to the direct cytotoxic effect, dysregulated RAS, endothelial cell damage, and dysregulated immune response, that it may end in cytokine storms. This is a most important slide in my presentation. That if you look to this slide, you may say that it is not an COVID, it is an SLE, which disease that can affect the neurology, renal, hepatic, gastroenterology, dermatology, endocrine, cardiac, thromboembolism. For me, I should put COVID-19 as a differential diagnosis for any rheumatic disease, especially systemic connective tissue disease, especially SLE in the coming few years. And this is a very important that it is not like infection, right? It's okay, there will be a long-term sequelae. especially psychological effect and fibromyalgia. So may have permanent organ damage, but still you may have long-term COVID-19 syndrome. In this curve, this is RA in comparison with the dotted one general population. Our patient is more liable for mortality, increased incidence of mortality in comparison with the general population. Other immune-mediated joint disease, it is second to RA. And this is for vaccination. The green one is the general population, and violet one, the patient with immune-mediated disease. And you can see the response is not matching general population. It takes longer time. And I saw the comment of Dr. Tamer, the vaccination will cover you for 6 months. That's why the booster dose is approved today by EMA and already approved by FDA to give the patient booster dose. I think COVID-19 will be like influenza and common cold. It will be long-lasting one. So this is the latest version that is published in October 2021 for guidance. And you can see that for hydroxychloroquine, there is a strong recommendation not to interfere. But if your patient is taking mycophenolate, you have to stop 1 week, methotrexate 1 week after, JAK, you have to stop 1 week, abatacept 1 week before the first dose, and then 1 week after the first dose. Cyclophosphamide and rituximab, you have to keep it away from until the next dose. Dr. Tamer said the patient developed cutaneous. I will not give this patient again after the second dose. I would make a resolution of vasculitis. Then I may try another vaccination, but we have to take for this patient ANA, we have to make for this patient ANCA, C&P ANCA to see if this is related to the vaccine itself or it is related to immune-mediated disease explored in a clear way after vaccination. And by this, again, sorry for this, and thank you for your kind invitation and wishing you a successful meeting, inshallah.
Thank you, Dr. Osam. Well, it's so clear now.
Thank you very much. Dr. Shankar, Assalamu alaikum.
Salam.
Any comments?
No more questions. We'll shift now to the second session. It's my pleasure and honor to present a dear Professor Dr. Muhammad Shakir. He is an orthopedic surgeon in King Faisal Specialized Medical Hospital and Research Center. He is the Secretary General of the Saudi Osteoporosis Society. Really, Dr. Shakir is a very eminent figure of osteoporosis and has very nice fingerprints in the field inside the kingdom. Dr. Shakir, do you hear me?
Yes, Dr. Khalid, Dr. Muhammad with us now. I am trying to fix the presentation. Just a minute.
Take your time.
Okay. Thank you. Bismillah ar-Rahman ar-Rahim. Thank you very much. I just get back from the hospital and sorry for the delay. Now, for the FRAX, we already know what FRAX is, or what FRAX was actually. Why we present FRAX again and again? Well, we know in the past that the fracture risk assessment, which depends mainly on, or one of the things that it depends on, the geographic location or the nation. And whenever you go to FRAX, usually we have FRAX of United States, of Canada, of Europe. In the Middle East, We used to have Lebanon, Jordan, Kuwait, etc. But Saudi Arabia was not among the countries with the fracture risk assessment tool available. Well, over the past few years, there was a significant or a lot of work to involve Saudi Arabia in the FRAX tool. And there was a lot of work done by the Saudi Osteoporosis Society with affiliation with the Ministry of Health. So we collect a lot of data about the fractured hip, and we submitted to the University of Sheffield with the FRAX people, Professor John Canis and his people, to include the FRAX in Saudi Arabia. Now we have very exciting time nowadays that FRAX is about to launch in Saudi Arabia. We already have what we call the beta version for those who are the, in the Saudi Osteoporosis Society to test it. And I think within the next few weeks, we will have the Saudi FRAX available. This is why we want to present FRAX again, so you can now appreciate what FRAX is, and now you can start using FRAX. Sorry. This is why we presenting FRAX again and again. And what's FRAX? I want to give you an idea over the next few minutes about FRAX and how to use FRAX. With in any disease, actually, the important question to ask whom we want to treat. And in hypertension or diabetes, we know that there is a limit, for example, for the blood sugar or for diastolic or systolic blood pressure. Beyond these figures, you will treat. And there was always a question, can we apply same principle to osteoporosis? Now, that will bring us to the question why we treat osteoporosis. It's nice to have the BMD looks better. It's nice to improve the turnover markers and make the bone stronger. But the main and the target for us as a clinician is to prevent fractures. We prevent fractures that really they kill people. Up to 25% of the hip fracture, victims will die over the next year from the extraskeletal complication. At some stage in the past, we thought only hip fracture kill people. Then we realized that even vertebral fracture can kill people. Well, and that is ذكرك قول الشاعر يموت الفتى من عثرة بلسانه وليس يموت المرء من عثرة الرجل فعثرته من فيه يعني من فمه ترمي برأسه وعثرته بالرجل تبري على مهله. طبعا الفتى أما الديرلي بيبل عثرة الرجل الكبير في الحقيقة لا تبرى على مهله. And the slide is stop moving. Do you see me here? Hello? Are we okay? Yes. So عثرة الشيخ لا تبرى على مهله. Now, those who survive the fracture or they stay alive, they have miserable kind of life. They lose independency and they go into all this sequelae of complications. So we want to prevent fracture. Now, if we want to prevent fracture, we have to determine who will fracture. And to determine who will fracture, this will take us to the guidelines on whom you treat. According to the North Society, if we screen ladies, women above the age of 65 and men above the age 50 or younger with risk factor, we screen them with DEXA. And if the T-score is minus 2.5 or less at any of the three sides, lumbar or spine, total hip or femoral neck, then at that level we treat, because we have plenty of evidences that offering intervention for these people will be cost effective and will be beneficial. Now we come to those who are a T-score between -1 and -2.5. In another word, they are osteopenic, not osteoporotic. Do we treat them or not? We ask the question, do they fracture or not? Well, that will bring us to the, why we treat patients. We know that the efficacy have been documented in patients at moderate to high risk of fracture, while the therapy is not cost effective in patients at low fracture risk. So we want to determine who are the people at high risk of fracture, at moderate risk of fracture, or those who are at low risk of fracture. Also, there is a very important concept, which is the risk-benefit ratio. Now, if you treat those with low risk of fracture, are we doing good? Are we submitting these patients might be to the side effects of the drugs that we use, and the risk-benefit ratio will work against you, not with you. So the best thing is that we should treat patients according to the fracture risk. And how to do that? Now, let's consider BMD and see how BMD will help us in determining the fracture risk. Now, if you take a look here to the vertical axis, the relative risk of fracture, and here you have the Z-score or the T-score, and you plot it against each other, you know that when you go down with your T or Z score, the risk of fracture will increase. And we know that with each standard deviation decrease in the BMD, you double your risk of fracture. So there is the exponential, inverse, and continuous relationship between bone mass and the incidence of fracture is there. And this is why we think that the diagnostic threshold, which is -2.5, it's those who are at this, they are eligible for treatment because there is an abundant evidence that the elevated risk of fracture in these patients with T-score below -2.5 is reduced by the intervention you give. Now, how about those people, as we said, who are osteopenic? And we want to know to treat them or not to treat them. And according to Shakespeare, that's the question. Now we ask, do they fracture or not? That will take us to a very important study, and actually many studies goes into the same direction as this study, which is known as the NORA study. NORA study by Ethyl series, which considered almost 250,000 patients, and she plot for us the rate. I'm talking here in this axis, the rate of fracture. And in the vertical axis, we consider here the T-score. So here we have patients below -1, and these patients are normal, between -1 and -2.5, and these are the osteopenic patients. Then we have after -2.5 or below -2.5, they are osteoporotic. Now, if you plot the rate, what you will find that the fracture rate, as you go more and more into osteoporosis, your fracture rate will increase gradually. Now, what happened if we start look at to the other side of the graph and start looking about the absolute number of the patients who fracture, not the rates. Here we look at the rate. Now we want to pay attention to the other side and looking at the absolute number. And I want you to take a look on the gray column, what happens here. Those who are osteopenic or designed as osteopenic, the number of a fracture is more than those who are osteoporotic. Why is that? Because at this stage here, we have fewer women. In another word, people die. And the rate of death outstrip the rate of fracture. This is why, in spite of that the rate is more, talking about percentage or per 1,000 or whatever, so the rate is low, but the absolute, the rate is high, but the absolute number is low. So we have to take care of those who fracture here and who have increased the number, which is here abundant number. So this study and another study show us that most hip fractures occur in women who do not have osteoporosis. And how the question comes now, how to find out those who are fracture more? What is the tool that will help us to define those people who are even not osteoporotic, but they have fragility fracture? I'll take you to this very important data from Malamo in Sweden. And here we consider the 10-year probability of fracture against the T-score of the femoral neck. And here in the vertical column, we're looking at the age, 50, 55, etc., 75, and horizontally, we're looking at the T-score, and as you can see, we reach to T-score minus 3. Take a look on this first example, a patient who is 70 years of age, at the T-score of minus 1.5, what's her 10-year probability of fracture? It's almost 15%. Now, this is osteopenic lady, but she is at the age of 70. Now, let's take a look in another example, a lady who is osteoporotic with T-score minus 2.5, but she is at the age of 50. What's her fracture probability? It's only 11. So that's what that tells you. That tells you age is an independent factor for fracture risk that add information over and above BMD. It's independent from BMD. And it's very important to know that. And this actually has a clinical application. We will mention that. So when we consider risk factors assessment, clearly we need not to take into account not only BMD, but also age. And by taking age and BMD, we improve our ability to determine who will fracture in the future and who will not fracture. And what is so in another word, the T-score impact on fracture is modulated by age. This is important clinically. Why? Because we see patients at the age, for example, 30 and 40 with the T-score of minus 2.5 or minus 2.7 or whatever, and somebody start them with anti-resorptive medication. And this is not right. Because here, the age works with these people against fracture. This is why premenopausal ladies, we don't offer them the active anti-osteoporosis medication again and again, because the age is a protective factor for them. Now, this is the age, how the age will affect the prediction of fracture. We'll take another example, which is a prior fracture. We know from data, accumulating data, that when you have wrist fracture in the past, your probability of having another wrist fracture more than threefold, vertebral fracture almost, and hip fracture twofold. When you have vertebral fracture in the past, then your probability of having another fracture is more than fourfold. Hip fracture is more than twofold. Again, what does that tells you? That tells you that previous fracture is important risk factor when we consider who will fracture. So taking age and a prior fracture in consideration will improve your ability to find out who will fracture in the future or not. So osteoporosis, we consider it a multifactorial disease, just like stroke, just like other diseases with multifactorial diseases. And in terms of fracture prediction, low BMD is only one risk factor. So those who are who depends only on BMD, just blindly see BMD minus 2.5 less other, then you decide that might be or should be reconsidered. So the question comes, can we target osteoporosis treatment for those patients who will receive the greatest benefit in a cost-effective approach? And that will bring us, what are the risk factors that will help us in predicting these fractures? So we have the expert from all over the world, appointed by the WHO, and they have a task to find out or to solve this dilemma. So they went to the different studies, all these cohorts from all over the world, and start looking into this issue. They came up with the FRAX model, module, the fracture risk assessment module. And what are these factors that will affect the fracture? As we mentioned, the prior fracture, the family history of, if there is a family history of fracture, patients who are smoking, this is also an independent risk factor and should be considered when we decide who will be treated or not. Steroid users, of course, if patient taking alcohol, rheumatoid arthritis, of course, the BMD, we don't neglect it, and the age. So all these factors are independent factors in predicting the fracture. So what that tells you again and again, all these clinical risk factors are adding information over and above that's provided by age, by sex, and or BMD. And more than that, FRAX, as I mentioned in the early in the presentation, is country specific. So it's important to use the logarithm of the of specific country. Why is that? Because the fracture hip incidence is different from one country to another. In areas like Denmark, for example, the fracture hip is very high, while in areas like Tunisia, Philippines, China, the fracture hip is low. So it is not fair to treat all the people or to consider all the people the same with this difference in the fracture rate. So we have people with very high risk of fracture, high risk of fracture, moderate risk of fracture, or low risk of fracture. All these countries will be categorized according to the risk of fracture. So in order to build a country-specific fracture, we need high-quality fracture data, which at the Saudi Osteoporosis Society and the Ministry of Health, we already had this information, this fracture data from all over the kingdom. Then we also have to have the country-specific mortality. Now, in the absence of country-specific fractures, and do you want to use fractures, what you can use, I understand that this, symposium, we have people not only from Saudi Arabia. So if you want to, you don't have fracture model in your country, what you will do, you will go to a fracture model of a country that has similar fracture rate to your country and similar age-specific mortality. For example, this is the life expectancy at the age of 60 of different, countries in the area. And you can see in Saudi Arabia is 17 for male, 19 for female, and 18 for both sexes. And this is something more or less similar to that of Oman, and I think also Kuwait, etc. So you submit all these data to these people in Sheffield University in England, headed by John Keynes, and they will include your data in the calculation tool. And how to go by this calculation tool? You just, if you have your mobile or computer, your computer in the front of you, just Google the word fracts. And the first thing you will have, University of Sheffield, you click on that, you will have this page. Now, if you have this page, you should, click on calculation tool. Whenever you click in calculation tool, you will have different parts of the world. And here you have, for example, Middle East and Africa. Now, if you click on that, you will have the countries. As I mentioned, we had in the past Abu Dhabi, Iran, Jordan, Kuwait, Lebanon, Morocco, Palestine, and Tunisia. Saudi Arabia is not there. Now, we can say that in a few days from now, inshallah, Saudi Arabia will be there. Now, how to use the fracts? These are, for example, I think this is Italy, for example. You click on Italy, on Saudi Arabia, and Kuwait, according to where you are or what kind of patient you're dealing with. And you have here all the data, the information. Then you fill up the information, male or female, the weight and height. Then you have all these risk factors: previous fracture, parenteral fracture, smoking, steroid, rheumatoid, secondary osteoporosis, alcohol, etc. Then you put your BMD. Now, after you fill up all these, you put, for example, for this lady, 70 years of age, with previous fracture, yes, other things all are not, and her T-score minus 1.4. Then you ask to calculate what is the absolute 10 years probability of fracture for this lady in this country. And we're talking here about major fracture, major orthopedic fracture, or major osteoporotic fracture, and hip fracture. So ask to calculate according to this fracture risk. This is the calculation. So over the 10 years, the probability of major osteoporotic fracture for that lady who's living in Italy or Italian lady is 11%. Her hip fracture probability is only 2.2%. Now, if we have exactly same information, but at a lady or a Swedish lady in Sweden, the fracture probability is higher than those in Italy. Then the number here you have for major osteoporotic fracture is 17. and hip fracture is 3.6, compared to the one in Italy was 11 and 2.2. Now, if we go to a lady who is in Turkey, or Turkish lady, the major osteoporotic fracture is 1.6. Hip fracture is 0.3 because fracture rate is less. US Caucasian, major osteoporotic fracture, same criteria, same T-scores. Then you have 25% major osteoporotic fracture, 2.2% hip fracture. US Asian, it will be 14 and 1.2. Now, what to do with this number? 14, 1.2, whatever. What to do with this number or with this figure? Well, I'll take you here to this graph, and we revisited again. You see here the T-score, we going into osteoporosis and the hip fracture probability, and we're talking according to the age here, age at age 80, 70, 60, and 50. Now, in the past, we used to have what we call the diagnosis threshold, which is minus 2.5. So those who are below minus 2.5, we offer them intervention. Those who are higher than minus 2.5, we don't give them medication. Now we talk about the intervention threshold. And the intervention threshold, we draw a line which is not a vertical line. It's a horizontal line. It is the threshold of fracture probability at which intervention became cost effective. And the cost effectiveness is different from one country to one country according to the wealth of the country, according to the priority of osteoporosis in the health system and treatment health system in the country. So we'll draw a line which is the absolute fracture risk. That's the line which we said before, these figures which are 20%, 3%, etc. This is your line that you draw. And it is a horizontal line. And in this horizontal line, those who are above the line with high fracture probability will offer them intervention treatment. Those who are below the line will not give them anti-osteoporosis treatment, will continue, of course, with lifestyle modification, vitamin D and calcium, etc., etc. And this line, how to draw this line? According to what's the economic status of your country. This line, for example, as we said, above that we will treat, below that we will not treat. Those who are people for example, in a poor country, you want to draw your line high up because the people still have to treat other health problem, which is, for example, polio, TB, etc., etc. Then you might draw your line a little bit high. Those who, in areas whom they don't find food or don't, water, you might even don't draw your line will sky high. Those with wealthy country, they finish with all the other health problem, or it is not a major problem. Then you might consider drawing your line lower so you catch up most of those who will fracture. So that will bring us again to we revisit our first slide. And we said that those who are minus 2.5 will offer them treatment. And we stop here and start discussion. Those who are between -1 and -2.5, what we will do, we will frax them and see what the 10 years fracture probability. And in the United States, and it's now accepted in other countries, but this figure should be actually studied according to the economic status of each country. So if your hip fracture probability is, more than 3%, or your major osteoporotic fracture probability is more than 20%, then you offer them treatment. If it is less than that, you don't offer them treatment. It has some limitation, the FRAX. It did not accommodate all known risk factors, for example, falls, biochemical markers, etc. Also, it lacked details in some risk factors. For example, it just says glucocorticoids. What's the dose of glucocorticoids? Is it the body of people who are taking 5 milligram, same like those who's taking 60 milligram? Smoking, those who are taking 10 cigarettes, like those who are taking 30 cigarettes, etc., etc. So again, it depends on adequacy of epidemiologic information, and still some countries, a lot of countries actually, they don't have their model. Actually, we will stop at this point about FRAX, and thank you very much. Hopefully, Saudi FRAX will be available for you within the next few weeks. Thank you.
Thank you so much, Dr. Shakir. A very nice presentation. And congratulations in advance for the Saudi FRAX, inshallah.
Inshallah, thank you very much. Inshallah, will be available for everybody soon.
Regarding FRAX, is FRAX of the all Arabic countries the same as well as the Middle East? Can we use interchangeably?
As I mentioned, you cannot, for example, in Saudi Arabia, use the FRAX of Lebanon, okay, because the fracture rate and also the mortality is different. But it's okay to use that of Kuwait, because we have kind of similar, similar data and the fracture probability and the mortality. So I usually, since we have the Kuwaiti FRAX, I usually use the Kuwaiti FRAX. But you cannot go to those who have, fracture risk or fracture rate is different from you.
Thank you so much.
Thanks.
Can FRAX be applicable for glucocorticoid-induced osteoporosis with different doses, small dose, moderate dose, or high dose?
Well, that is one of the drawbacks of FRAX. It says steroid. Now, as 5 milligram steroid is not like 60 milligram steroid. And this is one of the drawbacks. But definitely you can, those who are using steroid, definitely if you have your own, guidelines, if it is, for more than 3 months, you do your BMD and you check for the other risk factors and you offer them treatment.
Thank you so much, Dr. Shakir. Is exposure to sunlight enough to prevent or treat osteoporosis?
Exposure to sunlight actually is something has to do with vitamin D. For the vitamin D production in our body. It is definitely not enough to treat osteoporosis. It might be enough to supply you with vitamin D that you need, but remember that will be on expense of other risk of exposure to sunlight. We know that overexposure to sunlight can cause skin cancer, can cause early senility of the skin. So some of the dermatology societies, they don't like exposure to sunlight. And if you want vitamin D, which the sun will elaborate in your body, then you can go and take your supplement of vitamin D. If your food is poor in vitamin D, like most of the food in Saudi Arabia and everywhere, because our food is not rich with vitamin D. You can take the supplement of vitamin D. Usually, especially in Saudi Arabia and in this hot country, I'm against the exposure to sunlight for the purpose of vitamin D, production, because now we have vitamin D preparations, cheap, very effective.
As well as we have a poor culture for the sunlight exposure. Thank you so much, Dr. Shakir. Wallah, it's nice, very nice presentation to the point, as usual. Thank you so much.
Thank you very much.
Thank you so much.
Thanks.
You can stop sharing, Dr. Muhammad. From your side.
I mute myself, huh?
لا, stop sharing.
Stop sharing. Where is
at the bottom?
Yeah. New share? No. Stop sharing. Yes. I did.
Oh, thank you. Inshallah, we'll see you again this night also, inshallah.
Inshallah. Thanks.
It's my pleasure to present the next presentation. My dear friend and the very respected Dr. Ibrahim Al-Hamoud, he is a consultant rheumatologist. He is the chairman of the medical specialties department at King Fahd Medical City, as well as he is the chair of Saudi Rheumatology Scientific Board at the Saudi Society. He is the vice president of the Saudi Society of Internal Medicine, and he is the assistant professor at Al Faisal University. MashaAllah, a very big title. He will talk to us about scleroderma updates. تفضل دكتور إبراهيم. عليكم السلام ورحمة الله.
It's my pleasure to be with you today talking about scleroderma updates. First of all, I would like to thank the organizing committee, mainly and namely Dr. Khalid, for inviting me to be with you today. So, as we all know, there are several phenotypes of scleroderma. It's either localized or systemic scleroderma, which we call it systemic sclerosis. The localized scleroderma is probably not belong to rheumatology significantly, mainly with our colleague in dermatology. So what is important for us as rheumatologists is the systemic sclerosis. And as we all know, there are two types, mainly the limited scleroderma and the diffuse scleroderma. The silent scleroderma and overlaps are very rare entities. So what are the differences between the limited and diffuse? It's mainly based on the skin involvement. The limited form or the limited types involve the skin distal to the elbow and distal to the knees, as well as the face, where it spared the trunk and the proximal part of the limbs. Where diffuse, by its name, explained the nature of diffuse systemic sclerosis. Any part of the skin can be involved. Now, knowing that, it's very important when we talk about the systemic sclerosis approaching our patients, expecting the complications of the clinical manifestations, and then thinking about the treatment and the prognosis. If we handle a patient with this limited scleroderma, is mainly the clinical features are related to the vascular involvements and vascular complications, and therefore we should think about the treatment toward the vascular disorders that are associated with systemic sclerosis. Patients with diffuse systemic sclerosis, they have both manifestations, either related to the vascular disorders or to the inflammatory disorders, and therefore the treatment for a patient with diffuse systemic sclerosis might require immunosuppressive therapy or the vascular therapies that cannot be explored over the next 30 minutes. And then we should know that the systemic sclerosis is a very heterogeneous disease, and a patient might present to you with a skin manifestation mainly, while the other patient presents mainly with the lung-related disorders, which cannot be explored more in details with this speech at the end. Or it might be with the ulcers and Raynaud's phenomenon. So it's highly variable. It's very important to establish the diagnosis and then think about the pathophysiology of the clinical manifestations in order to make your plan for the treatment of such patients. So I'm not going to talk about the systemic sclerosis because it's beyond the scope of this talk, but I'm going to talk about the updates about this disorders. First of all, the disease duration at the time of death has increased significantly over the last few years from 10 to 15 years, which means that the prognosis, the survival rate of our patients, thank God, is improved with the improvement of the treatment modalities that's available nowadays. And the proportion of non-systemic sclerosis-related death increased from 30 to 57%. And that means the death reason for such patients is mainly related to non-systemic sclerosis manifestations. And this is very important to think about the complications that occur with these disorders if left without appropriate treatment. It's very important to keep in our mind the pulmonary artery hypertension and pulmonary fibrosis account for 50% of systemic sclerosis-related death. So this is one of very important changes and updates in dealing with the patient with systemic sclerosis. If you remember, traditionally in the textbook of the old textbook of medicine, when they talk or they write about the scleroderma, and they talk about the prognosis, we thought the most killer things in these diseases is the scleroderma renal crisis. But this has been decreased significantly over the last 2 decades. And that's probably after discovering and knowing the pathophysiology of these entities and the discovery of the ACE inhibitors and knowing the role of ACE inhibitors in treatment of this entity. So nowadays, although this is important, but we have to think about things that killing our patients, which is mainly pulmonary artery hypertension and pulmonary fibrosis. So the lung-related disorders are #1 killing of our patients with systemic sclerosis rather than scleroderma renal crisis. Now, as we said earlier, the systemic sclerosis is a very heterogeneous disorders. So when you have a patient with mainly skin manifestations, the recommendation is to make sure that he is having an adequate moisturized skin. So the dry skin will cause more irritation and more itching. And this is very important because most of us as rheumatologists, we think about steroid, immunosuppressive therapy, biological drugs. We tend to forget a simple approach, which is just ask or convince your patient to make their skin wet because the dry skin will aggravate the itching. Patient with the diffuse systemic sclerosis who presented to you early with the skin tightness, they might benefit from the immunosuppressive therapy. And which immunosuppressive therapy you could use methotrexate, and the evidence toward methotrexate for the skin is stronger than the other agents. But again, mycophenolate mofetil has been shown recently that it's very effective in treatment of systemic sclerosis in different aspects, including the skin and the lung manifestation. Cyclophosphamide could control the skin, but we all know the side effect and the complications that happen with cyclophosphamide. So this medications, we tend not to use it for treatment of skin manifestations only. So we used usually methotrexate. If your patient is not responding well, you could use mycophenolate mofetil, and azathioprine or MMF could be used as a maintenance if you are using cyclophosphamide, because we know from different rheumatological disorders, long exposure to cyclophosphamide is associated with a lot of side effects. Rituximab has been used and it also showed some improvement in the skin measures, but it's a biological agent and it's inexpensive medications, so we should not use it mainly for the skin. The oral steroid, which is always a debate, are we going to use the steroid for treatment of systemic sclerosis and the incidence of the scleroderma renal crisis? The answer, bottom line, is yes, you could use it, provided that you are using a low-dose steroid and you are observing and monitoring the renal function of the patients. So the EULAR recommendation in 2017 clearly indicated that methotrexate could be used for treatment of skin manifestations of early diffuse systemic sclerosis, because we know at the early time of presentation, there are an inflammatory process before tend to be fibrotic process. So if you catch your patient early at the time of inflammatory process, you give the patient anti-inflammatory medications and you could control the disease. So when we talk about the EULAR recommendation about the rheumatic phenomena, which is a very common manifestation in patients with systemic sclerosis, the EULAR recommendations, they recommended to start the dihydropyridine type calcium antagonist, mainly nifedipine, but also amlodipine could be used to treat the rheumatic phenomenon. And it has been shown that it reduced the frequency as well as the severity of the scleroderma-related rheumatic phenomena. The phosphodiesterase 5 inhibitors also has been shown to reduce the frequency and severity of the rheumatic phenomenon that is associated with systemic sclerosis. A meta-analysis of randomized control trials of prostanide IV ilioprost also reduced the frequency and severity of rheumatic phenomena. But remember, you need to give this as an IV medication, and it has to be given through the central line, usually under close monitoring. Such patients usually require either an ICU bed setting or HDU setting. So we tend not to use this medication unless the patient is having a very, very severe refractory rheumatic phenomena. So if you are thinking about the fluoxetine and SSRI, there is one small study that indicates could be useful, but the evidence is stronger with the calcium channel blockers, with the phosphodiesterase 5 inhibitors, and with the ilioprost. Now, if you have a patient with digital ulcer, if the rheumatic phenomena is severe, causing a lot of blood restrictions that result in the digital ulcer, in this situation, IV ilioprost has a very clear evidence to heal and reduce the frequency of the digital ulcer. But again, the limitation of the IV ilioprost, as I said earlier, it has to be in monitoring bed, usually in HDU or ICU. And it's not without side effect. The phosphodiesterase 5 inhibitors have shown also it reduce the frequency and the appearance of a new digital ulcer, and also healing of the persistent digital ulcer. And they are oral agents, so probably the first line in such situations is the oral phosphodiesterase 5 inhibitors. Now, bosentan, as we all know, it's very important medications, and it reduced the number of the new digital ulcers. But if you have a patient who already have a bad ulcer, bosentan probably is not as effective as the phosphodiesterase 5 inhibitors and ilioprost. So the recommendation in general, the first line, we use the oral medications, which is cheap, the calcium channel blockers, and also the ACE inhibitors have been shown to be effective. SSRI could be used with evidence, acceptable level of evidence. Phosphodiesterase 5 inhibitors are very useful to treat the rheumatic phenomenon associated with the systemic sclerosis. IV prostanoid, ilioprost, but we have to keep in our mind the limitation of these medications. Now, the palmar sympathectomy with or without botulinum toxin injection could be used in a patient with refractory cases. So this is the recommendation for the digital ulcers, and it's very important to think about the multidisciplinary team to involve our colleagues, vascular surgery, and sometimes we need even the anesthesiologist to be involved with us in patients who have severe disease that cannot be controlled by the mentioned medications. So what are the other manifestations of systemic sclerosis? The GI manifestation. And the GI manifestations, it's probably easy to be controlled because the PPI, it's available in almost all the hospitals, and we have good evidence that the PPI, the protein pump inhibitors, will control the GERD and dysphagia, and usually it requires long-term administrations. You start with a small dose and you tighten it up, and you can go to the maximum dose if you're tolerating these medications. The prokinetic dopamine antagonist might be used for dysphagia and reflux. parenteral nutrition should be considered in a patient who have severe disease, fail to respond to the oral medications, have a severe weight loss, and refractory to the enteral supplementations. Now, the intermittent broad-spectrum antibiotic, usually we use ciprofloxacin, is recommended for treatment for the intestinal bacterial overgrowth and when your patient is presenting with the diarrhea. Now we'll go to the most important aspects, which, as I said earlier, the things that killing our patients nowadays are the lung-related diseases, either pulmonary artery hypertension or the lung fibrosis. And pulmonary artery hypertension will take a little bit explaining why it's very important in scleroderma, because first of all, it is the second most prevalent type of pulmonary arterial hypertension after the idiopathic pulmonary artery hypertension. And systemic sclerosis is the most common cause of the connective tissue disease-related pulmonary artery hypertension. It's commoner than the mixed connective tissue disease and commoner than SLE. And the prevalence of pulmonary artery hypertension and systemic sclerosis ranging between 5 to 12%. And as I said earlier, the pulmonary artery hypertension and the pulmonary fibrosis are the most common cause of death in such patients. Not only that, pulmonary hypertension in patients with systemic sclerosis has the worst prognosis of any complications as in patients with systemic sclerosis. Most of the guidelines recommended annual screening of systemic sclerosis patients for pulmonary artery hypertension, and we should practice this one. I know most of us in our busy clinic, we don't do it, but we have to train ourselves to practice this, to do the screening annually for our scleroderma patients. Now, when we look to the REVEAL database, they found that the pulmonary artery hypertension associated with connective tissue disease, 62% is due to the systemic sclerosis. And then around 16% due to the SLE, and mixed connective tissue disease around 9%. So if you lumped all your patients under rheumatology practice who are having pulmonary artery hypertension, the majority, to almost 2/3 of your patients are systemic sclerosis. Now, how you are going to screen such patient, do the lung function test, and it has been shown that clearly declining DLCO is associated with pulmonary hypertension in patients with systemic sclerosis. So if you are monitoring the DLCO, the diffusion capacity in your patients annually, those who are having declining in the DLCO, they are at high risk to develop the pulmonary artery hypertension. Several studies try to look to the predictors of pulmonary hypertension in patients with systemic sclerosis, and they found that the DLCO to the VA, when it's less than 70%, the systolic pulmonary artery pressure more than 40 in echocardiogram, high ESR might be, but we have to be very careful when we interpreting the ESR, keeping in our mind ESR might be raised due to several reasons. Simple reason like anemia could raise the ESR. The elevated pro-BNP is a very good predictor factors for pulmonary artery hypertension. And probably the best predictor is the declining DLCO and increase the pro-BNP. So if you have a combination of declining DLCO with increment in pro-BNP, this makes your patient at a very high risk to develop the pulmonary artery hypertension associated with the systemic sclerosis. So, as I said earlier, the pro-BNP has been found that to be the best predictor with a sensitivity, as you see, 56, but the specificity is 95% in patients with systemic sclerosis. So it's not only a predictor. The elevated pro-BNP have been found to be correlated with the severity of pulmonary artery hypertension in patients with systemic sclerosis. As I said earlier, patients with systemic sclerosis who develop pulmonary artery hypertension have a significantly drop in their survival rate, and they have a very bad prognosis as compared to those without pulmonary artery hypertension. And I think this slide explains itself, indicating that we have to look to this disease or this manifestation as early as possible and treat this entity as quick and as aggressive as possible. Again, this slide explains the worst prognosis in a patient with pulmonary arterial hypertension and systemic sclerosis as compared with pulmonary arterial hypertension with SLE and mixed connective tissue disease. As you see, those with systemic sclerosis has the worst prognosis as compared with the other immune-mediated disorders. If you have a patient with systemic sclerosis and lung fibrosis, the mortality reduced significantly to 58 as compared to 84. If you have the pulmonary artery hypertension, it reduces even worse than the lung fibrosis to 27% with the pulmonary hypertension. So if it's with pulmonary artery hypertension only, it's 31%. And this explains how this disease is bad, or this manifestation is bad when it's occurred in presence of the systemic sclerosis. So I think this is very clear, explained by different studies in a recent literatures. So what is recently described, almost 8 years ago, this study, they did a screening program for a patient with systemic sclerosis to detect the pulmonary artery hypertension early, and they compare it with the routine practice, which is I and you doing it in real life. And they found that if you are practicing a screening program, you will detect all your patients before class 4. And the patient in class 3, instead of being 70%, reduce it to be 50%. And more than 50% of the patient will be detected in class 1 and class 2, which means clearly if you are applying a clear protocol, you will detect your patient with pulmonary artery hypertension earlier in the course of the disease. And is this beneficial? The answer is yes. And that's what we should look for, as clearly explained in this slide. The survival rate improved dramatically in those who went into the scanning or screening program, because it's simple. You detect the patient early, you treat the patient aggressively early, and then you prevent the complications that's related to the pulmonary artery hypertension. How you should do it? The detect screening algorithm has been published, and you should do it either by non-echocardiogram or by the echocardiogram. And you look for the pulmonary function test, and you look for the poor prognostic factor that predispose your patient to the pulmonary artery hypertension, such as telangiectasia, anti-centromere antibody, pro-BNP. Urate level has been found to be a risk factor for the pulmonary artery hypertension, and the ECG with the right axis diffusion. And then you calculate the points. It's a program that's very easy to be done. And then if not, you just observe your patient. If it's there, you refer your patient to the echocardiogram, and you calculate the risk points according to the result of the echocardiogram. And if the suspicious is there with the points more than 35, you have to. There is no excuse to do the right heart catheterization to confirm the presence of the pulmonary artery hypertension. If we look to the Australian screening algorithm, they depend mainly on the pulmonary function test and the pro-BNP, which is probably more practical. So if you have a patient with DLCO more than 70% and the FC to the DLCO is less than 1.8 and the pro-BNP is low, this is a low likelihood for the pulmonary artery hypertension. But if it's not, you go directly and you do the echocardiogram and you do the 6-minute walking distance. And if you suspect pulmonary artery hypertension, again, the gold standard to confirm the diagnosis is the right heart catheterization. So whatever you would like to use, but the most important one is to think about screening of any sclerodermal patient presented to your clinic about the pulmonary artery hypertension. And I would recommend to do the echocardiogram, the pulmonary function test, and the pro-BNP, because all of these things are non-invasive. And then you could apply the detect algorithm. It's an online, easy to be done, by at least 2 echocardiogram, pulmonary function test, and the biomarker that would help you to establish the diagnosis. There are several recommendations. There is no time to go through it, but just to draw your attention, there are an ACR recommendation for screening, and I recommend all the patients with systemic sclerosis to be screened for pulmonary artery hypertension. And that's not true for the other connective tissue disease, because we know the prevalence of the pulmonary artery hypertension is low in the other diseases. But in systemic sclerosis, it's really high and it's really killing disease, and it could be treated if detected earlier. And then the recommendation, it has been published and it's available online, free, you could access it. But just to draw attention that the pulmonary function test and echocardiogram is recommended in any patient with the scleroderma. And if you suspect, you have to do the right heart catheterization to confirm the diagnosis and to start the treatment. So we know now the importance of early detection of the pulmonary artery hypertension. What's about the treatment? There are several lines of treatment of pulmonary artery hypertension. And thank God now we don't have only one medication, we have several lines for the treatment of pulmonary artery hypertension, either through the inhibition of the endothelin receptor, or through the prostacyclin activation, or through the phosphodiesterase type 5 inhibitors. The same medications that used for Raynaud's phenomenon is also approved for treatment of pulmonary artery hypertension. The pulmonary artery hypertension treatment could be used as monotherapy or as a combination therapy. And as I said earlier, several outlines: the endothelin receptor antagonist, bosentan, ambrisentan, macitentan, or phosphodiesterase 5 inhibitors, sildenafil, taldefil, nitric oxide agonist, oral prostacyclin analog, and the others, as you see in this slide. Just to show you that recently we know that the combination therapy is superior to the monotherapy when you are treating the patient with pulmonary artery hypertension. And this has been documented in several RCTs. So nowadays, if you have a patient who is diagnosed with pulmonary artery hypertension, the combination therapy is the standard and the goal of therapy of treatment of such entities. So when we look to the guidelines, the EULAR guidelines for treatment of the pulmonary artery hypertension, the evidence, as you see in this slide, is good. We have very good evidence for the treatment of the pulmonary artery hypertension, either with the phosphodiesterase 5 inhibitors, with the other agents as mentioned earlier. So what also the other entities, and sorry, because of the time, I'll try to finish and then we'll open the floor for discussion. It's very important to also think about the interstitial lung disease, which again, as I said earlier, it is the other entities that's killing our disease. It has been associated with higher mortality risk, and the 9-year survival years has dropped significantly to be around 30%, as compared to 72% in a patient without a major organ involvement. So it's clearly that involvement of the lung in a form of interstitial lung disease will impact the prognosis of our patients. It's the second most common organ involvement in patients with systemic sclerosis after the esophageal involvement. We know most of our patients, they have some degree of gastroesophageal reflux disease. So the second most common organ involved is the lung, and affect both patients with either diffuse or limited cutaneous systemic sclerosis. So it is not uncommon disease. When we look to the biopsy and the types of the interstitial lung disease, most of the patients will have the UIB types, the UIB, which is usual interstitial pneumonia, in around 80% of the patients. If you are doing the pulmonary function test, the restrictive physiology will be there, and 40 to 75% of the systemic sclerosis patients will have restrictive pathophysiology in the pulmonary function test. What about the treatment of the interstitial lung disease? Now, previously, we all know cyclophosphamide from the SLS study that it's effective when it's given over 1 year. But the problem with the cyclophosphamide, in addition to the side effect, the response has been declined significantly after 1 year of stopping cyclophosphamide. So SLS2, which is comparing mycophenolate mofetil versus cyclophosphamide in a patient with systemic sclerosis and interstitial lung disease, they randomized the patient to MMF versus cyclophosphamide, and they did the HRCT at the baseline and the 24 months. And also they look for the pulmonary function test and the skin manifestation. As you see in the slide, both cyclophosphamide and MMF result in improving the lung function. in a patient with interstitial lung disease and systemic sclerosis. However, we all know the MMF is associated with less side effect and tolerated much better than cyclophosphamide. When we look to the skin involvement, it has been shown clearly the MMF improved the skin scores. So MMF could be considered as a DMARD in patients with systemic sclerosis because it changed the disease progression both toward the lung as well as the skin involvement. What about rituximab? Because we use rituximab a lot in rheumatoid arthritis and caseous vasculitis, SLE, and the other disease. Now, this study comparing cyclophosphamide versus rituximab in a patient with the early diffuse systemic sclerosis and interstitial lung disease. And the study met its primary endpoint. So rituximab, as you see on your left side, showed a significant improvement in the lung function test, in the skin scores, in the 6-minute walking test. And this study also shows a significant improvement in the secondary endpoint. So cyclophosphamide is effective and rituximab is effective. Not only that, rituximab showed the superiority over the cyclophosphamide in the study. We are, from King Fahd Medical City, publishing also in Annals of Thoracic Medicine 4 cases, a case series in patients with interstitial lung disease who were given rituximab, and 3 of them showing response, 1 of them deteriorated. So rituximab could be considered as one of the drugs that could treat and suppress the progression of the interstitial lung disease in the patient with systemic sclerosis. Belimumab, as you know, everyone is interested in B-cell mediated agents, including belimumab in treatment of systemic sclerosis, Sjogren's syndrome, and SLE. So belimumab has been used in systemic sclerosis, and it has been found that it's safe, but it doesn't show any statistical significant superiority to the placebo in efficacy toward the skin. So belimumab, it does not show any differences as compared to the placebo. Abatacept has been tried in a patient with systemic sclerosis and joint manifestation. And this study showed that abatacept might be considered in a patient with systemic sclerosis with a predominant musculoskeletal manifestations, those who have manifestations similar to rheumatoid arthritis, or we could say overlapped with the rheumatoid arthritis. Now, nintedanib, the name is a little bit difficult, nintedanib, has been approved for treatment of systemic sclerosis based on the study that shows, as you see here, a clinical significant improvement in the interstitial lung disease and the prevent of the progression of deterioration in the lung function test. So studies have been published, and then after that, it gets the approval for the treatment of the patient with the interstitial lung disease associated with systemic sclerosis. More recently, just a few months ago, tocilizumab, based on phase 3 focused trial, which has failed actually to achieve the primary endpoint that was toward the skin, but it showed a statistical significant benefit on the pulmonary function test, which was the secondary endpoint. And this led to clear conclusion and observation that it prevents the progression of the early systemic sclerosis associated interstitial lung disease. This study led to the approval in March 4, early of this year. Both subcutaneous as well as the IV tocilizumab has been approved for treatment of the pulmonary of the interstitial lung disease associated with systemic sclerosis. If you are looking to the EULAR guidelines, they recommended methotrexate and the recommended cyclophosphamide could be used, but we have to keep in our mind the data publication of these guidelines. This was published in 2017. So nowadays we know MMF is similar to cyclophosphamide and it's less side effect. And now we got 2 drugs that approved for the interstitial lung disease, the nintedanib as well as the tocilizumab, both approved after the publication of these guidelines. Renal scleroderma, as I said earlier, because nowadays it's very rare, we rarely see such entities, but it's very clear the treatment and the guidelines is to use the ACE inhibitors. Several studies suggest that if you are going to use the steroid in such patients, you have to be very careful. You could use the low-dose steroid safely, but you should monitor your patients. The GI recommendation, as I said earlier, the PPIs are very clearly recommended with a very good evidence to be used in pain systemic sclerosis. The antibiotic could be used for the treatment of bacterial overgrowth. So at the end, I would like to draw your attention that the systemic sclerosis is a very heterogeneous disease. And it's both fibrotic and inflammatory pathophysiology. So if you detect the patient in inflammatory stage, treat the patient with the anti-inflammatory medications, with the immunosuppressive therapy. Or if you have a patient with the inflammatory manifestations, inflammatory mediated manifestations, you could use the anti-inflammatory and biological agents. All systemic sclerosis, all should be evaluated for the lung fibrosis. And the treatment should be determined by according to the extent and the severity and the likelihood of the progression to the severe disease. All the patients should be screened for pulmonary artery hypertension annually. And the combination therapy for treatment of pulmonary artery hypertension has become the new gold standard for the upfront therapy. So please don't use upgrade treatment. Use the combination from day one you diagnose your patient with pulmonary artery hypertension. Mycophenolate mofetil could be considered as DMARD for systemic sclerosis, which is the first one we could consider it as DMARD because it's changed the disease progression by evidence-based quality level of evidence. There is a new approach for overall disease activity will likely include a new biological agents, as I said earlier, tocilizumab and nintedanib have been approved after publication of the recommendation, keeping in our mind the last recommendation now almost more than 3 years. At this point, thank you very much. And if you have any questions, you are most welcome.
Thank you so much, Dr. Ibrahim, for your nice presentation. A nice presentation from a nice brother.
Thank you very much.
As well as it is a very difficult topic. Scleroderma is the most easy to diagnose, most difficult to treat.
That's true.
One question, do we have an official approved DMARD in scleroderma, systemic sclerosis?
There is no approval by definition of DMARD, the disease-modifying anti-rheumatic drugs that modify the disease progression, nothing. The problem with skin, as you know, the skin might loosen by itself with the time in some patients. So it's difficult to approve patients that control the disease, the skin. However, now the mycophenolate study, the SLS2 has shown that it inhibits the progression of the skin as well as the lung disease. So could be considered as the first DMARD in systemic sclerosis, mycophenolate mofetil.
What biologic do you prefer in such cases, especially ILD?
Okay, now to be honest, the tocilizumab is recently approved. We have good experience with tocilizumab in rheumatoid arthritis. I personally used before rituximab, and I published rituximab experience with interstitial lung disease. Probably my practice, this is my own practice, will be shifted toward tocilizumab because it is the approved agent. But to tell you the truth, we use rituximab. We have good results so far with rituximab.
Thank
But I
you so
think
much.
we use the drugs that's approved.
Is there an explanation why the pulmonary arterial hypertension is more with limited form of scleroderma than the systemic one?
I have no explanation, to be honest. But this is, like interstitial lung disease, it's common with the diffuse. Pulmonary arterial hypertension is more common with limited.
Scleroderma is full of mysteries still. Thank you so much, Dr. Ibrahim. Nice presentation. Thank you so much.
Thank you. It's my pleasure.
Thank you so much. Jazakallah khair. Barakallah. Now we'll shift to the last presentation in the second session. It's my pleasure to present a very eminent figure, in Saudi Arabia. Dr. Hanan Al-Rais, she is a senior consultant rheumatology, deputy director of the medicine department, the director of rheumatology fellowship in Sultan Military Medical City, assistant professor in King Faisal University, as well as she is the president of the Saudi Society for Rheumatology. Dr. Hanan will present a nice topic, SLE and pregnancy. Welcome, Dr. Hanan.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, thank you, Dr. Khalid. Thank you for the invitation and for your active actually participation in the rheumatology field and with this yearly conference, and this is the 9th one. I would like to thank you and thank also the whole organizing committee. I'm happy to be with you today, presenting very common topic and very important topic to different specialty, which is the systemic lupus erythematosus with pregnancy. I don't know whether I'm sharing now the slide. Is it clear or?
Yes.
So I will start. It's there. Okay. So always the systemic lupus erythematosus and pregnancy is a fear, especially for patient as well as the doctor. We know that systemic lupus erythematosus is common in young women. We know it's very common in a female, for which she is in the childbearing period where she is planning to have kids and planning pregnancy. And always there is a fear from the disease itself as well as from the medication. And a lot of women, sometimes they stop their medication because they want to get pregnant. They came to us active with severe disease. So always we have to consider the pregnancy, the fertility from day one when we talk to our patient, when we start the therapy, when we choose the type of medication in this patient, and we discuss every aspect of pregnancy and fertility with our patient. So in the next maybe 20 minutes, I'm going to talk about the importance of pre-pregnancy assessment and counseling, especially the fertility, the type of contraception, the medication that is safe during pregnancy. And then we'll talk about the effect of pregnancy on systemic lupus erythematosus, as well as the effect of lupus itself on the pregnancy outcome. And special consideration on lupus nephritis during pregnancy and neonatal lupus. And if there is time, we'll talk about just 2 slides about antiphospholipid and pregnancy. Always we were asked whether SLE affects the fertility or not. Actually, several studies showed that there is no effect in the fertility in a woman in general with systemic lupus erythematosus, unless the patient have an active disease, or if she's having moderate to severe renal involvement, or she was exposed to medication that affect the fertility, like cyclophosphamide. But otherwise, patient with systemic lupus, she's as fertile as general population. This study, which is the previous study to show the effect of cyclophosphamide in the fertility with premature ovarian failure in those patients. And it was showed clearly it depends on the dose as well as on the age of the patient. And always we inform the patient if the patient with SLE less than 25, she's less likely to have premature ovarian failure, while those above 30, they are more likely to have premature ovarian failure. And of course, the cumulative dose is very strongly influence the rate of premature ovarian failure. So what to do for those patients who need cyclophosphamide? Always we have to weigh the risk. If there is other medication available or visible like MMF, which is preferred, so we have to give it to our patient. Unless it is life-threatening and no other medication, then we use cyclophosphamide. And if we use cyclophosphamide, it's preferable to be used with gonadotropin-releasing hormone antagonist to protect the gonad. And this study showed that in young women with severe SLE treated with standardized protocol of IV cyclophosphamide with gonadotropin-releasing hormone, and the second group without, and showed clearly that those who are protected with gonadotropin releasing hormone, they are less likely to develop premature ovarian failure. So only 5% develop premature ovarian failure compared to 30% for those without giving gonadotropin releasing hormone. How to give it? Usually we give it 22 days prior to start cycle, but we know sometimes in patients with severe disease who are planned for active therapy, we can give it concomitant with the cyclophosphamide. So we mentioned about the SLE and fertility, and this one from the recent recommendation from EULAR, and it was stated clearly that women with SLE who wish to plan pregnancy should be counseled about the fertility issue, especially the adverse outcome associated with increasing age and the use of alkylating agent, and it was 1A recommendation. And treatment with alkylating agent should be balanced against the risk of ovarian dysfunction, and if needed, we have to do preservation of the fertility by giving gonadotropin releasing hormone. What about using assisted reproductive technique? It can be used in SLE patient. Assisted reproductive technique such as ovulation induction. Always we ask about that, especially in patients with primary infertility or other causes that prevent fertility. It can be used safely, but we have to be sure that the patient is inactive, and we have to check the antiphospholipid. And if the patient have antiphospholipid antibodies, we have to use anticoagulant. And there is specific protocol for using these anticoagulant or aspirin. Let us take a case scenario. 26 years old woman with systemic lupus erythematosus for 10 years. She have a history of class 4 glomerulonephritis. She was treated with MMF 6 years ago, and she's off of MMF, but she got a creatinine of 2.5 and creatinine clearance of 22. I have this one. I have to, maybe, I don't know. I have like a line inside the screen. Anyhow, patient on hydroxychloroquine only, stable, and her antiphospholipid antibody, anti-Rho were negative. So is this patient fit to get pregnant or not? This is her question. So having glomerulonephritis ended with element of chronic renal impairment, even if it is mild to moderate, so it's considered one of the contraindication to pregnancy. So severe, what's severe disease related damage that is contraindicated for pregnancy? Severe renal insufficiency, severe interstitial lung fibrosis or pulmonary hypertension, severe cardiomyopathy or valvular disease, a history of CVA or MI. Also, the disease activity that we have our patient to get pregnant should be stable at least 6 months on treatment that is feasible for pregnancy. So it's not enough to be stable in MMF and then you stop it and change it to Imuran and then ask her to get to have a pregnancy. No, it should be shifted to stable medication or safe medication and observed for 6 months to be in remission or very low disease activity to be allowed to get pregnant. And the presence of several antibodies, I mean, high titer of antiphospholipid antibody or anti-SSA, anti-Rho is considered risky for this patient, but not contraindication for pregnancy. The only contraindication is, as I mentioned, severe renal insufficiency and pulmonary hypertension with severe cardiomyopathy or severe interstitial lung disease. So during preconception counseling and the risk, major risk factor should be discussed with the patient, and we have to monitor the patient blood pressure, and you have to use safe medication based on the recent recommendation by EULAR. So in our patient, because she's having chronic renal impairment and the serum creatinine clearance less than 30, so the option for this patient better to have an IVF or to wait for renal transplant, which is then when she got normal renal function, she can get pregnant. So what contraceptive pills is allowed for these patients? So in a patient where they are on medication not safe during pregnancy, or they have one of these contraindication for pregnancy, contraception should be the issue for them. And always we were asked, is it safe to give contraceptive pills? Yes. Based on this study, which was done published in New England Journal in 2005, and it showed that there is no difference in the when we give a combined oral contraceptive or progesterone alone, it's safe in a patient without antiphospholipid. So in just an SLE patient without any history of thrombosis or evidence of antiphospholipid antibody or syndrome, it's safe to give the combined oral contraceptive or even the progesterone alone if there is antiphospholipid antibodies. And the conclusion regarding contraception in patients with SLE, oral contraception may be safely prescribed in SLE patients, provided they are in stable condition, and they have negative antiphospholipid antibodies. We can choose the barrier method or progesterone as an alternative if patients have antiphospholipid antibodies, or IUCD can be used, but we have to be cautious because of increased risk of infection. What about the medication? Always we receive our patient coming to our clinic because some of the doctor, whether OB/GYN or family physician or other doctor, they inform her she's stable on hydroxychloroquine, and they inform her stop it as contraindication. So this is wrong. Low dose of prednisone as well as hydroxychloroquine is very safe. And actually, I will mention that several studies indicate using hydroxychloroquine during all pregnancy is indicated, and to prevent even the flare. So the drug that is used for prevention and for management of SLE flare during pregnancy is hydroxychloroquine, oral steroid, azathioprine, cyclosporin A, as well as tacrolimus. All is safe to be used during pregnancy and as needed. If the patient has a flare or moderate to severe disease, and we try one of these medication or combination without improvement, so during pregnancy, we can give pulse steroid, we can use immunoglobulin or even plasmapheresis in severe cases. So the aim, always we have mentioned it, the aim is to have quiescent disease for at least 6 months prior to pregnancy, because having that, the risk of flare and the risk of complication during pregnancy very low if the patient is in quiescent or remission state prior to pregnancy. The contraindicated to be used during pregnancy, the medication like methotrexate, mofetil, cyclosporin, as I mentioned, plus warfarin as well as ACE inhibitor in case of hypertension. So always we have to change to low risk and wait. This is the study of hydroxychloroquine. It's a prospective study which showed that the rate of miscarriage, stillbirth, and pregnancy loss in those patients on hydroxychloroquine was better in patients on hydroxychloroquine. And the degree of thrombosis activity during pregnancy was significantly higher in those women who stopped the hydroxychloroquine. So hydroxychloroquine, as I mentioned, is recommended preconceptionally and throughout the pregnancy. And this is the recommendation from ACR as well as the EULAR. So what is the effect of pregnancy on systemic lupus erythematosus? We know that pregnancy is a physiological process where we have a surge of increase of estrogen that lead to a shift of the immune response from T helper 1 to helper 2. And this was suppression of the cellular immunity and increase of the humoral immunity to keep the baby, to avoid rejection of the baby. Saying that, so autoantibodies we expect to be increased, and we expect we might have more flare during pregnancy with SLE. But several studies showed contradictory result. Some of them, if the lupus case is stable, the flare during first, second, or third trimester, they are equivalent to non-pregnant. that's why remission is indicated. But we know that some of the physiological pregnancy change sometimes mimic disease activity or lupus flare. Like they might have anemia, they might have some proteinuria because of increased glomerular filtration rate, as well as some tachycardia, some joint pain, which is sometimes related to the pregnancy rather than active disease. So normally a physiological adaptation of pregnancy, as I mentioned, occur, and we mentioned that it can mimic lupus activity. Let us take a scenario. A 32-year-old woman with systemic lupus erythematosus presented with history of arthritis and skin rash and found to have low platelet. Just I want to have the case again. Okay.
نفس السلايد ولا؟
لا هو السلايد اللي فاتت.
هي سلايد لم تتغير، يعني حضرتك تحب نغيرها شيفت؟
لا it's okay. So just to mention that patient with this is the one, and she's having an active as you can see.
حنان هي مش ظاهرة عندنا، هي بس patient number 1 بس.
الحين it's okay.
هي patient 1 هي دي اللي ظاهرة.
Which slide now? Is it lupus flare in pregnancy?
لا اللي هي first case. Patient 1 number 1.
So I'm moving the slide. Why it is not moved?
Can you make stop sharing and share again?
Okay. How can stop sharing?
From the bottom. Top or bottom?
Intro. What do you have now?
Same slide.
والله هذه التكنولوجيا دحين ايش اسوي لكم؟
Can you upload the presentation?
في حضرتك في ستوب شير هتلاقيها موجودة فوق.
هل الحين ستوب شير احط السلايد الحين اجين؟ لحظة.
وحضرتك تعملي شير تاني، شير سكرين مرة أخرى.
الحين شير سكرين واضحة؟
لا لسه.
أنا I'm sharing the slide غريبة.
لا يعني stop and reshare again.
I'm sharing the slide. صحيح ما هي واضحة. بس ما فين الاقي ستوب شير.
هي خلاص ستوبت خلاص. عايز اعملي بقى شير سكرين تاني.
بس حضرتك افتحي البرزنتيشن الأول.
كيف كده؟
تمام كده تمام. lupus flare in pregnancy.
اوكي طب دحين كويس؟ اوكي. So just to mention about how frequent to have a flare during pregnancy. Several studies show several percentage, and it range from 7 to 33% in a woman who have been in remission to have flare. So even if they are in remission, they might have a flare, but less than if it is active prior to pregnancy. As you can see here, it reached up to 67% if the patient have an active disease prior to conception. Okay, so SLE disease activity or flare, if at conception, it increased the risk of both maternal disease activity with relative risk of 2.1 and subsequent flare during pregnancy. It increased the risk of hypertensive complication with an odd ratio of 1.8, as well as it increased the fetal morbidity and mortality. So what is the risk? What increased the risk of flare? As we mentioned, if the patient have an active disease prior to get pregnant, patient with renal impairment, patient with positive high titer of anti-double strand DNA and even low complement, and patient with proteinuria. So lupus nephritis, whether an active or just a history, is a strong predictor of poor outcome, for both for the maternal outcome as well as the fetal outcome. And in this survey from obstetric hospitalized patients from United States of more than 3,000 delivery in lupus patients clearly showed that hypertensive complication with preeclampsia, eclampsia, as well as premature rupture of the membrane, intrauterine growth restriction, more frequent and more common in SLE pregnant patients compared to healthy. And even the long stay in the hospital and significant risk of cesarean section. So always we have to consider these two major complications that influence the pregnancy outcome, the lupus nephritis as well as the antiphospholipid syndrome. So lupus nephritis, as I mentioned, active lupus nephritis, whether it is class 3, 4, or renal disease reported, chronic renal impairment, and as well as women with chronic renal failure prone to higher rate of hypertensive complication and exacerbation of proteinuria. So in the presence of lupus nephritis, the fetal loss can reach up to 36%, abortion and miscarriage up to 31%, stillbirth and neonatal death can be reached up to 23%. So how we define renal remission, which is important during pregnancy. So if there is a past history of lupus nephritis with stable renal function and normal creatinine, then we have to have estimated to say patient in remission and stable to get pregnant. If the estimated glomerular filtration rate more than 60, the RBC CAS less than 5, proteinuria less than 0.5, and normal serum complement for at least 6 months prior to pregnancy. Here, this study in a patient with pre-existent lupus nephritis, the predictor of fetal and maternal, is a prospective study, found, as you can see here, patient with complete remission compared to non-nephrotic proteinuria, so was acceptable compared to patient with glomerular filtration rate less than 60. As you can see, more percentage of flare in patient with nephrotic syndrome and those with glomerular filtration rate less than 60. And here again, another study of showing a patient with pre-existent lupus nephritis, the predictor of fetal and maternal outcome, and these patients were having mild renal impairment. As you can see, the live birth was 91, spontaneous abortion of 8%, and stillbirth 1. And in these patients, actually, what we are looking in a patient with previous lupus nephritis, whether they have back to normal creatinine level or they have some renal impairment. So those who back to normal creatinine or creatinine clearance more than 60, they are fit for pregnancy with less risk for complication. Another case here, 30 years old woman with SLE, history of class 4 lupus nephritis 6 years ago, treated with MMF for 3 years. She's in remission now on hydroxychloroquine alone. Her serum creatinine 1.2. This is the one we have mentioned before with negative SSA, SSB. So as we mentioned, renal insufficiency, risk factor for poor fetal outcome. And as I mentioned, the fetal loss will be higher, and in this patient, if the creatinine clearance less than 30, we have to avoid pregnancy because of all of these complications. Another issue about high proteinuria during pregnancy, and always we don't know whether this is a physiological in a lupus patient or preeclampsia issue or this is lupus nephritis. So how to differentiate? Sometimes we need specific parameter because these parameters like blood pressure, usually with lupus nephritis, it might be high, but in preeclampsia, definitely it's high. The platelet, usually in physiological proteinuria, it's normal, but it can be low in preeclampsia and can be low in lupus nephritis. So how to differentiate? Uric acid, usually high uric acid in preeclampsia with normal uric acid during lupus nephritis. The rest complement usually normal in preeclampsia and low with lupus nephritis. And with active disease, active lupus nephritis, we might have high anti-double strand DNA and normal in preeclampsia. Of course, the hematuria is mainly with lupus nephritis, very possible in preeclampsia, but usually more toward lupus nephritis. And active urinary sediment that indicate lupus nephritis rather than preeclampsia. And sometimes active lupus elsewhere, apart from the renal, CNS, or skin, and so on. So indicate this is most likely active lupus with lupus nephritis. And of course, the response of steroid is mainly with lupus nephritis and not with preeclampsia. So pregnant patients with lupus have increased risk of preeclampsia, 13 to 32 versus a healthy woman. And the risk of preeclampsia is mainly in a patient with pre-existent hypertension, if the patient have an active lupus nephritis or established chronic kidney disease, and if she got antiphospholipid syndrome. What is the suggested treatment for this patient or prophylactic? If this risk factor is available in a pregnant patient with systemic lupus erythematosus, we prefer to give them aspirin, small dose, 100 milligram. It can reduce the risk of preeclampsia and reduce the risk of infant death and even reduce the low birth weight. Sometimes we need low-dose heparin if patients have antiphospholipid, of course, antibody there. Here, a case of lupus nephritis treated with MMF for years. And she's planning to get pregnant with renal flare. She was changed to azathioprine, but while she's on azathioprine, she got flare. So we put her back on MMF, and she's quiescent for 1 year. So the issue, like what I have mentioned before, when we want to have our patient in remission, patient should be in remission with a safe medication, not in remission with medication that is contraindicated for pregnancy. So we shouldn't allow them to get pregnant while they are on medication that is contraindicated. Now, what is the effect of lupus in pregnancy outcome? We mentioned that SLA pregnancy. So lupus is, per se, is a risk for spontaneous abortion, especially if they have antiphospholipid antibodies. But again, even without antiphospholipid, there is some data indicate that can increase spontaneous abortion, preeclampsia, intrauterine growth restriction, fetal death if there is antiphospholipid antibodies, and of course, preterm delivery and cesarean section more with SLE patient. The degree of risk increase in relation of these risk factors. So if more than one risk factor, the degree is more. History of previous thrombosis, as I mentioned, and the other like lupus nephritis increase all of these complications, active lupus and so on. Here, a study of 166 pregnancy in 125 women from Johns Hopkins, and showed increased pregnancy loss, like 16% within the first trimester. And in those with secondary antiphospholipid more, I mean, you can see here 3-fold increase of pregnancy loss. So whenever we have more risk factor, we have more of complication of pregnancy. Just because of the time, I will pass this one, and I will talk a little bit about neonatal lupus. Please just stop me, Dr. Khalid, if the time is running. So neonatal lupus, again, one of important issue, and always we discuss it with the patient. Always we screen lupus patient for anti-Rho antibodies, anti-La, because if it is present, like 2% they might have complete heart block, but up to 20% they might develop neonatal lupus with different degree. Like neonatal lupus can be just skin rash, or it can be with mild thrombocytopenia, anemia, or might have the full picture with complete heart block. So the complete heart block only if in a patient with high titer of anti-Rho, it can be up to 2%. But if the patient have previous heart block, then the subsequent pregnancy will be increased up to 16 to 18%. So we mentioned that they might have several manifestations, but the commonest is skin rash and sometimes just cholestatic hepatitis. So what is the role of anti-La in the development of neonatal lupus? The anti-La response to major B cells epitope and can pass the placenta and can affect the patient, the neonatal heart and lead to complete heart block sometimes, or different degree of block. That's why in patients with positive anti-Rho, anti-La, we have to monitor the pregnancy as early as 16 weeks with serial echo, especially if there is previous complete heart block. So it should be weekly at 16 weeks up to 26 to detect early the block and manage the patient. But if patient have no previous block, it can be done at 16 weeks, then every 2 weeks. Any management, actually there is contradictory about the management, but the fluorinated dexamethasone, if we detect early, I mean second degree or detect the third degree block within 1 week of this follow-up ultrasound, then you have to give 4 milligram dexamethasone until improvement. We have to weigh the risk, but to prevent the complete heart block, this is the management. Sometimes more severe complication like severe hydropic fetalis, that fetus that we need plus with dexamethasone, we have to maybe do apheresis for rapidly removal of the maternal antibodies and save the baby. And here is the recommendation of the echo, as I mentioned. So in the management recommendation, as we mentioned, patients should be in remission. We have to monitor the disease activity. In the first visit, in the first trimester, we have to do full examination, full assessment of the patient. And we do CBC, anti-Rho, anti-La. We have to check the antiphospholipid antibodies, the anti-DNA, the serum creatinine, mandatory and 24-hour urine for creatinine clearance and protein. And then we do monthly visit, evaluate the patient for activity. And then at each end of trimester, we have to do the 24-hour urine protein and creatine clearance. We have to check the complement and anti-DNA for the activity. And of course, the ultrasound assessment of the baby to avoid IUGR or any other complication. And of course, the fetal heart only if there is positive anti-Rho antibodies. The treatment we mentioned, we have to choose the safest therapy and depend on the severity, we choose the therapy. The predictive biomarker for maternal disease activity, as I have mentioned, it was published in the EULAR. So assessment of the disease activity, including renal function, important serological marker with complement as well as anti-double-strand DNA and monitoring with the ultrasound. What about antiphospholipid syndrome or antiphospholipid antibody? So if like this scenario, a patient with lupus on azathioprine, hydroxychloroquine, and she got persistently positive lupus anticoagulant and high titer anticardiolipin antibodies. She gave a history of intrauterine fetal death at 18 weeks. So with this scenario, is she antiphospholipid syndrome? So she's an antiphospholipid syndrome because she got a clinical as well as serological. So just for those who are not rheumatologists, persistent high titer of IgG or IgM anticardiolipin or beta-2 glycoprotein or positive lupus anticoagulant with one of these clinical criteria that indicate antiphospholipid syndrome. And in this patient, in patient with lupus, the antiphospholipid antibody can occur up to 30 to 40%, but clinical antiphospholipid syndrome in lupus patient only in 10% reported to 15. And here, different studies showed the different titer of antibody during in patients with SLE. So in women with antiphospholipid syndrome, whether it is primary or secondary antiphospholipid in SLE patient, the high titer is a risk for sequelae of the disease activity as well as the outcome. And we have in these patients to start treatment. It depends whether it is just antibody or syndrome. So all patients with SLE and positive anticardiolipin antibodies or lupus anticoagulant should be on low dose aspirin. But if they are definite antiphospholipid syndrome, then we have to give heparin, low molecular heparin treatment dose with aspirin in a patient who get pregnant while they're having this syndrome. All of these data were given from evidence-based, and from these two actually references good for those who want to review the subject of lupus in pregnancy. In a summary, we have to educate our patient as early as possible and frequent, because always patient forget, and if she is stable, she stop her treatment because she want to get pregnant. So always we have to recommend the appropriate contraception if she is on one of the medication that is contraindication for pregnancy. We have to rule out serious underlying disease related damage, and we discuss it with the patient. We have to have a good timing for pregnancy, and to review always the medication with the patient. We have to counsel the patient and her husband ahead of time to avoid complication. Hydroxychloroquine should be continued throughout pregnancy and post-pregnancy with close monitoring by different specialty. We have to be aware of active disease during pregnancy and how to estimate the activity. And we mentioned about the safe medication. And thank you for listening. Sorry for the interruption in between the slide.
Thank you so much, Dr. Hanan. It's a very interesting presentation with a very difficult topic. Regarding IVF, induction of ovulation, is it hazardous?
Yeah, it can activate the lupus. That's why we have to choose the time, and the best time when the patient in remission. And we give small dose of aspirin, like 75 or 100. And if the patient have antiphospholipid antibody positive, we have to start heparin. And these should be stopped at the time of ovulation. So the aspirin like 3 days before, and even the heparin should be stopped at the time of induction itself. And then we resume it once the patient get pregnant. 3 days. Yep.
Prophylactic dose يعني.
Yep.
طيب, the last one is the ideal contraceptives in SLE.
We mentioned it. If the patient have no contraindication for thrombosis, SLE per se, we can give them the usual combined. If they have positive antiphospholipid antibodies, better to avoid the combined, and you can give like IUCD, or we can give progesterone alone.
Thank you so much. جزاكم الله خير دكتورة حنان for your acceptance for the invitation. We are proud of your presence. Thank you so much.
Thank you. Thanks. الحين stop sharing. هي دي مشكلة stop sharing.
Yes.
لقيتها. Okay.
Thank you. And it's my pleasure and honor to present my dear friend, Dr. Mohammed Al-Umair. He is the Assistant Professor and Consultant of Rheumatology, Faculty of Medicine, King Saud University in Riyadh. It's my pleasure, Allah, and honor to present you, Dr. Umair. He will talk to us about strategic trials in ANCA-associated vasculitis. Please, Dr. Umair.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Khalid, for the invitation. It's a pleasure and honor to be along with you and this important update for colleagues who are not practicing the rheumatology field. My first talk would be on ANCA-associated vasculitis strategic trials. So I'm going to talk on the studies that have shaped the standard of care for patients with ANCA-associated vasculitis, and what will be the future perspective for these patients. These are my disclosures, and this is going to be my agenda. Now, the ANCA-associated vasculitides are a group of rare diseases characterized by the presence of ANCA positive antibodies, in addition to systematic involvement in these patients. The aim of treatment is basically at controlling disease activity and taking patients into remission with the lowest amount of medication possible, and to prevent organ damage. Now, usually granulomatosis with polyangiitis, previously named as Wegener granulomatosis, and microscopic polyangiitis are clustered together in clinical trials because of their similarity in clinical manifestations, while eosinophilic granulomatosis with polyangiitis is somehow different and has its own clinical trials. Now, in view of the prevalence of ANCA-associated vasculitis ranges between 2 to 5 per 100,000. So it's a rare disease. The spectrum of disease severity is wide, so patients can present with pulmonary hemorrhage, glomerulonephritis, and end up in the ICU. And some patients might just present with chronic sinusitis, recurrent ear infection, or lung nodules. So there is no one size fits all, and the standard of care for these patients has been decided based on their organ involvement. This is an old classification of ANCA-associated vasculitis, which maybe many of the colleagues do not use it. So we usually use limited and systemic disease as an easier way to classify ANCA-associated vasculitis. Now, we could start with a case. So this is a 40-year-old woman who is admitted through the emergency room with dyspnea and oliguria, so hepatopulmonary syndrome, which ANCA-associated vasculitis is a very important differential in addition to lupus in rheumatology. Now, her examination is showing positive desaturation and bilateral co-crepitation. She has bilateral alveolar infiltrate. She has dropping hemoglobin, high creatinine with active urine sediments. So how would we manage this patient? Of course, in the management of ANCA-associated vasculitis, you have two phases. You have the induction phase, which compromises the first 6 months of therapy. And the aim is at reducing this activity to low disease activity or remission. And the cornerstone for induction in ANCA-associated vasculitis are cyclophosphamide and rituximab. Now, there have been alternatives for localized disease, which include methotrexate and cotrimoxazole. Now, cotrimoxazole is an antibiotic that has been shown to control the effect of ANCA-associated vasculitis, and possibly through its anti-inflammatory effect, but also through the antibacterial effect on nasal Staph aureus, which plays an important role in the disease activation and pathogenesis. But in real life, nobody uses cotrimoxazole alone. Usually it is used as a prophylactic therapy for patients who are on cyclophosphamide or mycophenolate mofetil or rituximab. This is an old EULAR guideline published in 2016, which is basically guiding clinicians how to treat patients with non-organ threatening disease, organ or life-threatening disease, or worse, rapidly progressive renal failure or pulmonary hemorrhage. And you could see the induction includes cyclophosphamide and rituximab in the first two. But in non-organ threatening disease, you can use methotrexate or mycophenolate. Then considering plasma exchange, which we're going to talk about, then patients who are refractory will be reevaluated for possible therapies in clinical trials. If patient goes into remission, he will go into maintenance. Now, the cyclophosphamide clinical trials, I will simplify them for you. So there are no trials comparing cyclo to placebo. There are studies that compared oral versus IV. You have 4 clinical trials that have shown that the response rate is the same. So oral is more potent marginally, but has more statistically significant adverse events because of the cumulative dose. So the standard of care now is to use intravenous cyclophosphamide. The first study is the Cyclops study, which compared the IV versus oral. And you could see at the end of the slide that the rate of response at 6 months is 78% in the IV, and oral has an 88% with no clinical significance, only higher numerically. While the NORAM study has compared patients who have early systemic disease, but a creatinine less than 150 micromole, and compared oral cyclophosphamide versus a higher dose of oral methotrexate than we use usually in rheumatoid arthritis, and it has shown a closer remission rate between the two. Now, to note is that the time to remission was longer in the methotrexate group with more extensive disease or pulmonary involvement, and the relapse rate was higher in the methotrexate group. So you have a safer drug, but more adverse events. So methotrexate should be cautiously selected in patients in view of the induction. Now, in 2010, when rituximab has been shown to be effective in many rheumatic diseases, the RAVE and the rituximab clinical trials were both published in the New England Journal of Medicine, showing that rituximab is not inferior in cyclophosphamide as induction in patients who already failed cyclophosphamide or are naive to cyclophosphamide. The rituximab had worse patients with more patients with renal failure on dialysis or having creatinine of more than 500 micromolar. So rituximab works on all range of disease, or milder disease or more severe disease. Now, a patient had induction therapy with pulse steroid followed by high dose cyclophosphamide for 6 months and 4 sessions of total plasma exchange, and reached remission with the Birmingham vasculitis index of 0. Now, prednisolone is at 15 milligram. How do we maintain the therapy? Now, maintenance therapy usually starts after 24 weeks, and the main problem is the rate of relapse. So the GPA and MPA are relapsing diseases. The first study is the Cicazarim, which compared continuing cyclophosphamide versus switching to azathioprine, and they found that the relapse rate is about 14 and 15% in both groups, with no difference between them and less side effects in the patients receiving azathioprine. Then another study which used cyclophosphamide as induction therapy. Then patients were switched to methotrexate or azathioprine if they achieve remission at 6 months, and it showed a mirroring effect of response and adverse events. Now, rituximab is basically a more expensive drug that has been a standard of care in patients with unconscious vasculitis. 3 studies have used rituximab as a maintenance therapy, and you could see when compared to azathioprine, the rate of relapse in rituximab is quite lower, 5 versus 29, with a p-value less than 0.0001. The MANRISTAN 2 is actually a study that showed that if you use a tailored therapy, so it's a physician decision when to reinduce with the rituximab versus fixed dose, has shown no statistical significant change, but there is a higher relapse rate in patients with the tailored therapy, 17.3 versus 10%. The MANSTREAM 3 is actually telling us that you need to continue rituximab beyond 2.5 years because the relapse rate will increase. So basically you have to continue rituximab for at least 3 years and then rediscuss the case with the patient, space the rituximab dose, reduce the rituximab dose by 50% from 1,500, but discontinuing rituximab in the first 2.5 years will lead to a higher hazard ratio of relapse. MMF does not have clinical trials. Most of them are observational open label studies, and a systematic review have shown that MMF has some effect in controlling ANCA vasculitis and is considered a standard of care when patients have contraindication to other medications. Now, combining etanercept to cyclophosphamide in the WIGET study have led to a red signal in the development of 6 malignancies in the etanercept arm, and the study was terminated. And you could see below, surprisingly, that there is no first author in the study. So the paper is only cited by the journal and the date without the name of first author. Now, the PIXIVAS study started in 2009, and this study took about 10 years to be completed. And basically, the aim of the PIXIVAS was to see the impact of adding total plasma exchange to standard of care, and as a second phase of the study to see the impact of standard dose glucocorticoids, which usually 1 milligram per kg, or a maximum dose of 60 milligram of methylprednisolone or prednisolone, versus a reduced dose of about half, and the impact on total mortality and relapse rate. And these patients, just of note, or previously, the MEPEX study have shown some effect of total plasma exchange in view of the renal recovery, but no effect on mortality. So the PIXIVAS was to answer what the MEPEX trial had not answered. And the beauty of the PIXIVAS that it has given rheumatologists a clear way to put steroid tapering into action rather than the hazardous way we use, that everyone uses the dose that he thinks. Some colleagues goes even into 2 milligram per kg, which is not actually the standard of care. If a patient has a weight of more than 75, you can go to maximum 75, but remaining patients will go into 50 or 60 milligram of corticosteroids. And you could see at the end of 1 year, the patient should reach a dose of 5 milligram. And I think that this is an important standard of care that we need to develop in our cases. And similarly to this study, the giant cell arthritis clinical trials are also putting tapering steroid plans so that rheumatologists do not overuse corticosteroids because of their negative effect. Now, the PIXIVAS have shown that neither the plasma exchange addition or a higher dose of glucocorticoid affect all mortality going into 6 years of response. And now we believe that less steroids and not adding plasma exchange to all patients would be the standard of care. Now remember that the number of patients with diffuse alveolar hemorrhage was not very high. So patients who have diffuse alveolar hemorrhage might still benefit from total plasma exchange. So total plasma exchange is not completely taken off from the care of patients with ANCA vasculitis, but we could believe that maybe renal failure and RPGN might not respond to total plasma exchange. There is now more increased interest in the EGPA because of its eosinophilic predominance. And now there are new drugs for asthma that block IL-5 that might be of benefit in patients with EGPA. And mepolizumab clinical trial have shown a positive effect in reducing the flare rate of unconscious of EGPA in patients who has asthma phenotype rather than internal organ involvement. And so this is an event-related study looking at hazard ratios rather than looking at p-values between study groups. And you can see here the hazard ratio and the odds ratio of relapse in patients with mepolizumab versus standard of care. Now, as you know, corticosteroids are main standard for induction maintenance, but they also play an important role in the development of comorbidities and end organ damage. And there are two studies that have been published on a drug called avacopan, which is a small molecule that inhibits complement 5A receptor and affect neutrophil chemoattraction and activation. The first is a phase 2 study on about 70 patients, which showed positive effect. Then a large randomized controlled trial in ANCA vasculitis was recently published in New England Journal of Medicine, showing that avacopan compared to prednisolone had less relapse rate. Now, remember that avacopan is a new therapy, is expensive. We don't have long-term safety data on it. So prednisolone will still remain the standard of care in the case that we use it in the most or the wisest way possible. But once we have more data on avacopan and the price is reduced, going into a standard that can be paid by authorities and payers and insurance, maybe avacopan one day in the next decade will replace prednisolone in the treatment of ANCA vasculitis. Future trials that are published in the clinicaltrial.gov evaluate the use of leflunomide versus azathioprine in maintenance, the use of abatacept in relapsing non-severe GPA, and the new fashion of treating with induction of rituximab, then followed by lulumab for maintenance. So in conclusion, the outcome of the treatment of ANCA vasculitis had dramatically improved with the availability of treatment options. Despite of the high response rate at induction, relapse is still a major problem. Tapering and decreasing steroids cumulative dose is important to prevent long-term complication and will be the subject of future trials. The Pixivas was the leading one. Avacopan is a promising drug that might replace corticosteroids once we have more data and a reduced price. With this, I would like to conclude, and thank you very much.
Thank you so much, Dr. Omer, for your nice presentation. It was really a difficult topic, but you presented it nicely, mashallah. We have a question regarding a patient with alveolar hemorrhage and rapidly progressive glomerulitis. What's your recommendations to start with and to maintain?
So basically, let's take the steroid. So still pulse therapy with 1,000 milligram or 500 milligram for 3 to 5 days is still considered a standard of care in these patients with life-threatening disease or organ-threatening disease. But what I really advise colleagues is that you need to go really fast on tapering the steroid, whether you use the 60 milligram or you go to the now new standard, which is 30 milligram. Now, in view of induction, you have rituximab and cyclophosphamide, and both are equal. Based on the characteristic of the patient, you would go with rituximab or cyclophosphamide, but we tend to go more with the rituximab because of its better safety profile and because you will eventually put a patient on maintenance rituximab. So basically, rituximab is considered the best maintenance therapy. So better to start with rituximab and continue with rituximab instead of starting with cyclo and then switching with rituximab. But all options are the same. Treatment of or prevention of complications like giving PCP prophylaxis with cotrimixazole, gastroprophylaxis, and early rehabilitation, the need of dialysis or continuous renal replacement therapy in the ICU. All of these need to be all incorporated. Now, my final advice to my colleagues is that ANCA-associated vasculitis are rare but very serious diseases, and they need to be always managed in a tertiary care center. So colleagues who do not have the adequate experience or the facility, they need to refer these patients as soon as possible. And these patients get transferred from one ICU to the other. So once a colleague refers a patient with ANCA-associated vasculitis, this is a red carpet for the patient to come to a tertiary care center.
It's nice. What this new Avocapan, is it approved or not yet?
No, not yet. The two studies are published now. One was in the Journal of American Academy of Nephrology, and the second one was the New England Journal of Medicine. Again, few experience, very expensive medication. It will have a long way till it becomes a standard of care.
Thank you so much, Dr. Amir. Very nice presentation, concise. Thank you so much. We'll shift. It's my pleasure and honor to reintroduce my dear Professor Dr. Mohammed Shakir for a second new nice topic about the management of fracture risk. Dr. Mohammed Shakir, as I mentioned before, is a very eminent figure in the field of osteoporosis and has very nice fingerprints in the field in the kingdom. He is the Secretary General of the Saudi Osteoporosis Society. Please, Dr. Shakir.
Thank you, Dr. Khalid. Thanks for all to include an orthopod among all these highly calibered rheumatologists. And move these slides. Yes. So I want to start my presentation with this case. Nothing actually fancy. A lady with osteoarthritis of the knees, 77-year-old, presented for left total knee replacement, and that was almost 9 years ago. During surgery, the thing gets dramatic, and the lateral femoral condyle fractured, shredded into multiple small pieces. So the surgeon has to change his plan into this kind of modular system with offset. So the patient was sent home, and a year later presented to the emergency room with acute back pain. And this is a screenshot of her MRI, show old and new compression fractures. A BMD done at that time, and the T-score of the femoral neck minus 3.3 and spine minus 2.4, which is not a true representative of what's going on in the spine because of the degenerative changes. So the patient was started on zoledronic acid. A year later, she had the second dose of zoledronic acid. Then after almost few months after the second dose of zoledronic acid, the patient had this BMD, and it showed that there is increase almost 12% in the bone mineral content. So the patient received the third dose and fourth dose of zoledronic acid. Then a few months later, patient again actually had BMD, and it showed improvement in her bone mineral content. Then 2 years later, the patient, of course, they stopped the zoledronic acid, just continue with vitamin D and calcium. 2 years later, The one who's following her up did a BMD. As you can see here, there is a dramatic drop in the BMD and the bone mineral content of her femoral neck. She lost all the gain and she went almost 4 or 5% below the starting point. So the one who's treating her started there with denosumab. Now, a few months later, presented to ER with a very trivial trauma and the fracture of the metatarsal. Of course, you can argue that the fractures of the small bones of hands and the foot not considered as fragility fracture. However, the patient insisted that the trauma was very, very trivial. A few months later, a couple of years later, the patient continued with denosumab, actually. And after finishing the 3 doses of denosumab, she presented to ER with acute back pain again. As you can see, her spine, the T12 almost turned into a vertebra plana, and you see the T12 more and more compression. So to summarize, over 8 or 9 years, and despite the use of all of these potent anti-resorptive, patient continued to fracture, and the suffer recurred again and again, and the bill, of course, significantly increased. Now, what to do? Well, in order to understand what to do, let's sit back and ask the same question we asked in the first presentation. Why we want to treat osteoporosis? Because we want to prevent fractures. And in that lady, did we achieve our goal with the treatment that we give her? Apparently we did not, because she continued to fracture. And this is the main thing, or when you say that there is a failure of treatment in osteoporosis, number one comes into the list is patient continue to fracture. And whenever you have such situation, you start asking yourself questions. Is the patient compliant? Yes, the patient was compliant. She was on, IV zoledronic acid and denosumab, and these usually patients come to the hospital to take them. So she was compliant. Any underlying cause for fracture recurrence, the patient was investigated, and there is no underlying cause. The medication she used were not good? No. The medication she used, they are excellent. We have these molecules are potent anti-resorptives and potent anti-osteoporotic treatment. Now we left with the question, are the medications she used not enough? Well, the one who's treating her said that we follow the current guidelines, first line, second line, etc. Well, apparently following that guide or those guidelines was not enough to achieve our goal, which is fracture reduction. And because, and we know the same scenario, fracture continue to occur, patient families continue to suffer, morbidities continue to strike, and bill continue to grow up. Now, again, what to do? Let's ask what has happened, trying to find out an answer of what to do. We know early from medical school, as we age, our bones start to grow in size, change in shape, and become stronger. And that is a model. Then later on, we have the remodeling by which the bones start to change. So the old fragile bone removed and the new bone comes into, fill up the gaps which created by the osteoclast. Now, and this is our bone mineral density over the ages. We know that when we grow up until the age of 30, 35, we reach our, maximum bone strength. Then we start to lose until we enter in the area of osteoporosis, somewhere around here. So there is continuous decrease in the bone mass after the age of 40 and postmenopausal age. But the question, is this all what happened? Just decrease in the bones, in the bone mass, or there is something else? We know as there is decrease in the bone mass, as we age, there is also deterioration in the bone quality, and we start to lose the trabeculae, and the trabeculae become cord-like structure instead of a blade-like structure.
خلقكم من ضعف ثم جعل من بعد ضعف قوة ثم جعل من بعد قوة ضعفا وشيبا.
That is a true, description of what happened in our life, and also this will be applied to our bone. So as we age, again, we start to lose the trabeculae. They become like cord-like structure, and most important, we start to lose these horizontal struts, which are very important to resist any force that fall in the bone. And the engineers know the importance of these horizontal struts in any of the structure that they construct. And this is the femoral neck. As you can see, this here you have the longitudinal, and you have these struts which are important again for the resisting the load that lies on the bone. And this is from Eiffel Tower. You can see how these again structures, how they tie them up with these horizontal struts, same like what you see in the femoral neck. Now, when we come to remodeling, all these aspects of the bone will be deteriorated. The microarchitecture, we lose what we mentioned now, the struts, the mass, the size of the bone, the geometry of the bone start to affect it. Then the mineralization. So we start to gradually lose our bone strength. And this will compromise, as we said, the bone strength. And this is why when you have kind of axial load on your bone, normal bone, this is normal bone, you can hold it. However, when you have same axial load into osteoporotic, severely osteoporotic bone, it starts to buckle and fracture, and the sequelae of that, the compression fracture, and etc. So what has happened? The patient has the bone become so fragile and the structure become so interrupted that put the patient in very high risk of fracture, or what we call imminent risk of fracture. Now, in order to know what this imminent risk of fracture, which is that patient, our patient, the one we just mentioned, is one of them, we have to go into these, criteria. Number one, the BMD. We know that the BMD, as we mentioned before in the first presentation, whenever you go down with the BMD, your fracture risk increase. However, if your BMD is minus or T-score minus 2.5, this is your fracture risk. Now, if you go to -3, for example, what happened to your fracture risk? It is more than double. So -3 carry a risk for imminent risk of fracture, high risk of fracture. -2.5 is not like -3 when we talk in terms of fractures. And that is one factor that and the definition of high risk fracture. So very low BMD carries very high risk of fracture. Keep this in mind. Now we come to another factor we talked about in the previous presentation. Whenever you have your first fracture, the probability of having another fracture would increase dramatically. So this patient, one of our patients, in 8 weeks, started with one fracture. In 8 weeks, 3 fractures. Then in 10 weeks, we have almost 4 or 5 fractures. So there is a fracture cascade. And according to what you read from all these, trials, the fracture, relative risk of fracture will increase up maybe 7 or 8 folds by having the first fracture. So what that tells you? Multiple fractures carry very high risk of fracture. Is that all? No. We come to what I call time sequence. In that, if the patient has a fracture, the probability of having another fracture is highest during the first year after the fracture. When he passed or she passed the first year, the probability of having another fracture is less. As you can see here, this is the risk of second fracture, and this is the time and the probability of having another fracture more and more in the first year. And again, risk of subsequent fracture is highest immediately after the event. So if you have a patient with a fracture, you have to work quickly to prevent another fracture, because this is, the first 12 months carries high risk of fracture. And this is what I call, as I mentioned, time sequence. Now, what that tells you? Recent fracture within a year carries very high risk of fracture. So these we talk about very low BMD, previous fracture, time sequence, all these carry very high risk of fracture. Is that all? No. Do we have another criteria? Yes. Well, these are what we mentioned about recent fractures, multiple fractures, very low T-score. Then fractures while on approved osteoporosis therapy as our patient. This is very high risk of fracture. Fractures while on drugs causing skeletal harm, like glucocorticoids. Also, this carry high risk of fracture. Then high risk of falls. Then we talked about an hour ago about fracs. And we said fracs at 3% for a hip fracture, 20% for major fractures. These are the cut-off line for treatment. Now, if this fracs for major osteoporotic fracture more than 30%, or hip fracture more than 4.5%, then again, this carries very high risk of fracture. These actually, the new guidelines. The new guidelines by the American Academy of Clinical Endocrinologists, as well as by the International Osteoporosis Foundation and the Endocrine Society in Europe, all in the last couple of years have in their guidelines the concept of very high fracture risk. And I think this concept will be embedded in other local guidelines within the next 2 years or 3 years. This is very important concept, and this is a new development that we should pay attention to. So very high fracture risk or imminent fracture risk. Now, this is, as we mentioned, one of, I mean, the high or imminent fracture risk. And the question comes here, is this the usual scenario you and me face in our day-to-day practice? No. I mean, this patient will continue to fracture. This is not the usual scenario, but we face it from time to time. So that will bring question, is fracture risk the same across osteoporosis spectrum? Of course, no. I revisit this slide, and again, I want to emphasize that fracture risk at -3 is not like fracture risk at -2.5. So fracture risk is not the same. And we do have, it's not the same as we mentioned, we do have low risk, high risk, and very high risk. And that is the new stratification of the fracture that we must start to apply in our daily practice. So what's the definition of the high risk, very high risk, and low risk? We come to this paper, which we mentioned before, the guidelines for the Clinical Endocrinology Society. And as you can see, that's in February 2020. And this is what they mentioned. I walk you through this. They said the stratification of fracture risk categories. And they mentioned that when starting a treatment, it is appropriate to stratify patients by level of fracture risk. Since this may influence the selection of initial treatment. And that is in the American guidelines. If across the Atlantic, you go to the Europe, as I mentioned, this is from the Endocrine Society in Europe, and this is from John Canis and his group in IOF. All mention about this stratification of fracture risk. This is from the IOF. You can see low risk, high risk, and very high risk. Now, what is the definition of these things? Very high risk, we just mentioned it, but we will again repeat it. If one of or more of the below is true, fracture within the last 12 months, and we know why, multiple fractures, fracture while on osteoporosis therapy, fracture while on medication harmful to the bone, very low T-score, below -3, and fracture probability, which is 30% and 4.5% for major osteoporotic fracture and hip fracture, respectively. Then we come to the high risk. What is the high risk? If any of the below is true, of course, postmenopausal ladies, prior fracture, but she passed the 12 months. After 12 months, if she passed the 12 months, this will transfer her from very high risk into high risk. T-score, of course, -2.45 or less, or osteopenia with fracture probability more than 20% and 3%. Low risk, if all of the below are true, postmenopausal, no prior fracture, T-score, which is, below more than -1, and fracture probability below 20% and 3%. This is very important. I encourage you to take screenshot of this, slide, because this will be your future practice in treating osteoporosis. So now we have this stratification. Any stratification, any classification, if doesn't have clinical impact and decision that you make up, it is nonsense. So this stratification has also an impact on our practice, and we have to tailor our decision according to our patient and the the fracture risk. So in osteoporosis, I want to explain that to you. In osteoporosis, if you don't, this is osteoporotic bone. If you don't interfere, the bone become more osteoporotic. Now, if you, and the integrity of the bone, of course, decrease. Now, if you interfere with your anti-resorptives, all these nice, good drugs, what you will do, you will maintain the trabecular architecture, increase the mineralization, and stabilize the BMD. In another word, you stabilize your bone and you prevent fracture. Now, in our patient, as we mentioned before, in spite of all these strong, good medications, she still continues to fracture. In spite of increasing her BMD, she continued to fracture. So we have situation where a preservation and strengthening of the scanty bone that we have is not enough. And we have to think out of the box, as they said. And we have to, to come to this bone, which is very osteoporotic, jeopardized, the strength is gone. البون لسان حاله يقول عريت من الشباب وكان غضا كما يعرى من الورق القضيب ألا ليت الشباب يعود يوما فأخبره بما فعل المشيب. Well, this bone, we want something that will, bring the youth years to the bone. نرجع له الشباب. هل نستطيع أن نعيد للعظام شبابها؟ Well, apparently we have the molecules which are the anabolics. The anti-resorptive cannot do that, but the anabolics, and we have many anabolics on shelf nowadays, the anabolic can do that, can rebuild up the bone, and instead of stabilizing the bone with the anti-resorptive, you increase the integrity of the bone. Well, as we can say that the anabolic can do it it's not only from my drawings, but if you go to the same guidelines that we mentioned before. And if you go to the conclusions here, they said the review of evidence or expert opinion to support recommendations for medication based on category of fracture risk. And to go further in that, and I'll walk you through this paragraph because it's very, very important. What they said here, that it's intuitive that agents which stimulate bone formation, the anabolics, and restore degraded bone microarchitecture could be expected to have greater effects on BMD and fracture reduction than those that inhibit bone breakdown, which is anti-resorptive. In another way, in severely jeopardized bone with high risk of fracture, the anabolics better than the anti-resorptive treatment. Then they continue, I give you examples. Consistent with this, an increased body of evidence documents superiority of anabolic agents. For example, from results among patients treated with glucocorticoids. What happened? Well, this is what happened. You compare the alendronate, which is potent, good anti-resorptive, and it's indicated for steroid-induced osteoporosis. When you compare it with teriparatide, and as you can see, 36 months of lumbar spine BMD and vertebral fracture, here you see the percent of BMD, and in yellow, the teriparatide, and in orange, the alendronate, you can see the difference. Now, the vertebral fracture, vertebral radiograph, you can see in the alendronate is 7.7%, while here is 1.7%, and the clinical vertebral fracture in alendronate, they are for teriparatide 0. This is why they said, so teriparatide produced greater lumbar spine BMD 7% than did alendronate, and greater reduction in vertebral fracture incidence 6.1% versus 0.6%. Similarly, in high-risk patients, teriparatide produced greater increase in BMD and greater reduction in incidence of vertebral fracture than risedronate, and that is the VERO study. In VERO study, these are the demographics, and these are patients with high risk of fracture. They have previous fracture, etc. Again, you compare here the anabolic, the teriparatide, with good anti-resorptive, the risedronate in red, teriparatide in blue, and this is the fracture reduction, relative fracture reduction. After 12 months, it's 48%, and after 24 months, it's almost 56%. And here we're talking about a new vertebral fracture. Then the third example, providing further support for the superiority of anabolic therapy, patients who received 1 year of anti-sclerostin antibody, the romosozumab, which is the new, anabolic, experienced substantially reduced vertebral fracture and incidence of clinical fracture than alendronate. And this is the study, which they just mentioned. This is the alendronate, and in red, and the Romo, then in I think in the blue. And you can see in 12 months, there's reduction 37%, and in 24 months, it's almost 50%. So that will bring us to the conclusion of these 3 guidelines, that patients with low risk of fracture, and we define what they are, what you will do for them, optimize calcium and vitamin D and reassurance, and of course, you can follow them up, and offer them treatment if they move to another category. High risk, and we know what's high risk, then here you consider oral bisphosphonate or other inhibitor of bone resorption like denosumab. Now, very high risk, then you consider the anabolic agent. And whenever you give anabolic agent, after you finish with the anabolic agent, you gain your benefit, then you have to maintain the gain with the anti-resorptives. And with this, I think I finish my presentation, and thank
you. Thank you, Dr. Shakir, for this nice review of osteoporosis management. Really nice, yeah. Thank you.
Thank you.
We have just 2 questions about the newly approved medicine, Evenity. What's your experience with it?
with what?
اللي هو the
The Roma.
yes.
Yeah. Let me. Did I stop sharing first? Because
yes,
I think I stopped sharing. Anyway, good. Yes. Personally, I don't have yet experience with it. I mean, because it's just newly approved in the kingdom. It is not yet approved in our hospital, and my practice is restricted to King Faisal Hospital. I know a lot about it. I mean, from literatures but clinical experience, I don't yet have, and I think lots of thought leaders among the audience also still they don't build up that considerable experience with it. But it is, it is welcome addition to the menu of osteoporosis treatment, and it carries really a good hope for our patients. It works like anabolic, and at the same time, it's anti-resorptive. As we can see with the bone markers, when you start, the markers of bone formation will increase, and of course the markers for resorption will decrease. So it has kind of dual action.
Yes, thank you so much. The last one regarding glucocorticoid-induced osteoporosis. For how long do we treat?
As long as the patient needs. As long as the patient needs treatment. In osteoporosis now, the general rule, okay, we treat as long as the patient, even with teriparatide, which we were restricted to 1.5 years or 2 years. Now the FDA opened the treatment as long as the patient needed, because we were restricted in treatment, worried about the osteosarcoma. Is that right? Well, that proved that we don't have osteosarcoma with teriparatide in use in a human after 20 years of use of this medication. We have literature to prove that. So as long as the patient needs treatment, we should continue with treatment.
Thank you. Thank you so much, Dr. Shaker. We are so thankful and proud for your share with us. Inshallah, in the next future conference, inshallah, we'll have a share also, inshallah.
Inshallah.
Thank you so much.
Thanks.
It's my pleasure to reintroduce my nice friend, Dr. Mohammed Romer. As we mentioned, it's my pleasure to present him again, Assistant Professor and Consultant of Rheumatology and in Faculty of Medicine, King Saud University. Inshallah, I will talk about the second topic for pregnancy this night, about rheumatoid arthritis and pregnancy. Further, Dr.
Thank you, Dr. Khalid. I'm sure that most of the audience are a little bit tired, so I'm gonna make sure that the lecture will be quick and light, and hopefully to add some value to the understanding of rheumatoid arthritis in pregnancy, and what is different than what my colleague Dr. Hanan Reyes have covered in the lupus patients.
Inshallah, مسك الختام.
Inshallah. So basically, rheumatoid arthritis is the most common cause of inflammatory arthritis worldwide, and rheumatoid arthritis tend to affect women more than men in their childbearing years. It is important to always consider parenthood when you take decision on treatment plans and the care of these patients. So a good relation between the clinician and the family, including the patient herself and her spouse, to ensure that you have the lowest rate of unplanned pregnancy in your practice. Now let's go to the first concept, which is well known to everyone, rheumatologists and non-rheumatologists, and even undergraduate students, that RA improves during pregnancy. And if we look at the literature, this is a schematic review looking at all of the literature talking about improvement of RA during pregnancy, we could notice that most of the studies had either retrospective or prospective study design, but many of them used patient-reported outcome measures and non-objective measures to evaluate improvement during and after during pregnancy and after delivery. But it is a clear phenomenon that all clinicians managing patients with rheumatoid arthritis during their pregnancy have seen it, and we all believe in it. Now, as you know, RA is a polygenic disease like most traumatic diseases, and its HLA phenotype that increases the risk, HLA-DRB1, is well known to interact with T helper cells that lead to a vicious circle of cytokine release and immune cell activation, which include interleukin-6, TNF-alpha, as the main pleiotropic cytokines in the pathogenesis of RA. Now, we know that Th1 pathway predominate in the first years of RLAB, but Th2 get activated later on and plays a more important role. Now, we all know that pregnancy is a unique immune status because the body of a woman is receiving a semi-allogenic fetus that is having barriers not to attack this fetus during childbearing. And some of these mechanisms that suppress the immune system in the mother play a role in the improvement in RA. Now, we do not understand why this does not happen exactly the same like in other autoimmune diseases, but I'll try my best to give you the best hypothesis in the literature why patients with rheumatoid arthritis have a 50 to 75% chance to improve their RA, leading to reduction of therapy or even discontinuation. Now, if we took the mechanisms that have been described, in human studies, they believe that the increased level of cortisol during pregnancy plays a role. The Th2 shift during pregnancy might play a role. The development or reduction in the autoantibodies also play a role. Now, in some animal studies, they believe that prolactin might also play a role, or estrogen, and that allogenic pregnancy is associated with increased amelioration of arthritis compared to other. And there are many comments on these points. I would not take you into the details. But one of the theories is that the increase of T regulatory cells, which are the military police of the immune system, leads to a significant drop in cytokines, acute phase reactants, and might be the major player in improvement in the RA during pregnancy. So T regulatory cells are a subtypes of T cells that cause immune checkpoint and controls the immune system. And abnormalities in T regulatory cells or B regulatory cells have been shown in most autoimmune diseases to be a major player in the development of the disease. So you could see that pro-inflammatory cytokines and the CD4 T cells are the major players of inflammation, but also we have anti-inflammatory cytokines, including IL-10, IL-4, IL-33, and IL-35, also play a role in controlling the inflammation in addition to T and B regulatory cells. Now, what we have as available approved therapies for rheumatoid arthritis is really enthusiastic for all people who are joining the field right now. We are in the golden age of rheumatology, especially in the field of rheumatoid arthritis. You could see the number of biologics we have, the new JAK inhibitors, and In addition to that, the immunosuppressive agents or conventional DMARDs, in addition, of course, to the oral and intra-articular corticosteroids. Now, when a patient gets pregnant, the compatible drugs are reduced significantly. So in the biologics, you have only the TNF family available. You have sulfasalazine, hydroxychloroquine, and the corticosteroid as safe drugs to be used in pregnancy. Now, these are real cases. So I'm gonna quickly share with you 3 case discussions that might help to understand how the clinician and the patient need to discuss all of the issues before going into taking a decision in these patients. So Sarah is a 28-year-old lady. She's a lawyer. She's diagnosed with seronegative RA for maybe 4 years in the private clinic and started methotrexate and adalimumab. She reached remission in my clinic within a year, and after 3 years, we have succeeded to stop all of her therapies. We had a planned pregnancy. Actually, she discussed with me the time when she got engaged and she was pregnant, so I could explain to her all of the issues during the engagement, marriage, and the use of contraceptive pills. And she got pregnant. She dropped at the clinic at week 28 with a massive right knee effusion. The aspiration revealed clear fluid, so there is no septic arthritis, there is no other features. What would be the next step is to give her oral steroids, put her back on adalimumab, or give her intra-articular steroids, or combination of the following. And actually, in this patient, when you have monoarthritis, you always tend to go with intra-articular treatment, hoping that you don't need to take the patient into the systemic therapies and their complications. The second patient is Najat. She's a 32-year-old lady, restaurant cashier. The first visit, she dropped into my clinic. She was pregnant at 16 weeks. She came with a very active disease with more than 20 swollen joints. She was in severe pain, disabled, not able to go back to work. And she was managed by her previous rheumatologist with hydroxychloroquine and prednisolone. Now, what would be the next step? Would be to add an anti-TNF, would to add sulfasalazine 1 gram BID, or increase the dose of prednisolone and methylprednisolone. And in these patients, you need to really be aggressive because they are disabled, they are in severe pain, and they have a very high burden of inflammation that will lead to joint damage and destruction and disability if we don't treat them at these difficult times. So we have 5 anti-TNFs, and certolizumab is considered the safest. And the reason is that certolizumab is a pegylated anti-TNF with a very high molecular weight that does not cross the placenta. And this has been shown clearly in the CRIB study, which used certolizumab concentration in pregnant ladies and in the amniotic fluid, that certolizumab does not cross the placenta and does not get transferred to the baby. And this would not lead to any delay in their live vaccine of the fetus or the baby once delivered. The CRADLE study has shown similar data in view of breastfeeding, where certolizumab is not excreted in the milk or is below the detected levels. The last, and I hope that no one see this kind of patients, but I have come across 1 or 2 of these patients. A 38-year-old lady, housewife with RA on methotrexate, and she did not have any babies for the last 10 years, so she's not using any contraception despite our advice. She had an unplanned pregnancy. She came to me crying in the clinic. She has been doing really well in remission, and there is always the concern of methotrexate teratogenicity. Should we request an abortion? What we need to do? And because of not only the medical decision, but also the cultural and religious factors in patients, the decision of abortion need to be taken cautiously. Now, what we usually tell patients that methotrexate dose that is usually used in rheumatoid arthritis is quite low. And many patients who are on methotrexate, even if they go over unplanned pregnancy, they usually do well and they don't have any events. So this patient had an eventful pregnancy and had a healthy baby who's now about 5 years old, and the story ended in the best way possible. So in conclusion, unlike patients with lupus or other autoimmune diseases, RA patients have a more benign pregnancy course due to the intrinsic factor, which many are still not known to us. RA has the biggest number of therapeutic options to manage active disease during pregnancy, especially anti-TNF therapies. Individual's care with patient engagement is important and require direct communication between the rheumatologist and the obstetrician. With this, I would like to thank you and appreciate the colleagues who are staying with us till the end of the lecture and ready to answer any question.
Thank you so much, Dr. Omer, for your nice presentation. We covered all aspects of pregnancy, I think, this night. Yeah.
صحيح. It's important to have always this multidisciplinary care between the rheumatologist, the obstetrician, and any other specialty like the nephrologist or the pulmonologist once a patient has other organ involved.
Thank you so much. You looked very, very tired. Thank you so much, Dr. Omer. It's our pleasure and honor to share with you. Alhamdulillah. جزاكم الله خيرا.
بالعافية.
الله يبارك فيك. Inshallah, we'll close this session today, and inshallah we'll restart tomorrow, inshallah, second day at 4, inshallah, Mecca time, inshallah. Thank you so much, and see you, inshallah, tomorrow.